One piece of housekeeping before I bring in the witnesses. I would like to welcome, looking on the housekeeping, no?
I know we do.
Okay. I'd like to welcome our witnesses from the Department of Health and the HSE to our meeting this morning to discuss Sláintecare. I welcome from the Department of Health Mr. Robert Watt, Secretary General, Mr. Maurice O'Connor, Assistant Secretary, Mr. Bob Patterson, Principal Officer, Mr. Jack Nagle, Principal Officer, and Ms. Caroline Piggott, Principal Officer. And from the HSE, I want to welcome Mr. Paul Reid, Chief Executive Officer, Ms. Yvonne O'Neill, National Director, Community Operations, Ms. Anne O'Connor, Chief Operations Officer, Mr. Liam Woods, National Director, Acute Operations, and Ms. Yvonne Goff, National Director, Change and Innovation. All witnesses are again reminded of the long-standing parliamentary practice that you should not criticise or make charges against any person or entity by name or in such a way to make him, her or it identifiable, or otherwise engage in speech that might be regarded as damaging to the good name of the person or entity. Therefore, if your statements are potentially defamatory in relation to an identifiable person or entity, you'll be directed to discontinue remarks, and it's imperative that you comply with any such direction. So can I call on Mr. Watt to make your opening remarks?
Good morning, Chairman and members. Thank you very much for the invitation to be with this committee to discuss progress on the implementation of Sláintecare. As you mentioned, I'm joined by my colleagues Maurice O'Connor, Caroline Piggott, Jack Nagle and Bob Patterson. The Oireachtas All-Party Sláintecare report sets out the Sláintecare vision for a universal health and social care system where everyone has equal access to services based on need and not ability to pay. I'm happy to report today, alongside my colleague Paul Reid, CEO of the HSE, that Minister Donnelly and the government are making significant progress in delivering on this reform agenda. Of course, the background to this discussion is the COVID pandemic. This took up much of our management time over the last 2 years, which unfortunately slowed down several reforms, but it also, I think, demonstrated the benefits of a universal approach and also demonstrated the capacity of the system to change and respond. The COVID response by necessity accelerated many positive aspects of the Sláintecare vision. This included fast-tracking service innovation, new pathways of care, new ways of working, and changes implemented rapidly in line with the Sláintecare vision and principle. In effect, these changes accelerated the move from a hospital-centric system to one or more services are provided in the community and near a person's home. With the unprecedented funding support from government over the last number of years, and again this year, it is now our challenge to galvanise a system to build on these reforms. Of course, the context for healthcare reform is the need, which I think is generally accepted, to change a system that is not structured around the new and emerging needs of our population. Our population is ageing rapidly. By 2028, there will be more people aged over 65 than under 14. We are living longer, thankfully, but many of us will be living with one or more chronic illnesses. The Health Service Capacity Review, prepared in 2018, projected the demand for healthcare to 2031 will grow significantly. For example, it projected increase in the demand for primary care of 46%, 39% for long care, residential care, and 20% for home care. These increases are clearly not sustainable, and we need to continue to develop a more efficient, integrated healthcare system that can meet these growing patient needs. Chairman, I would like to focus, there are many aspects of Sláintecare. I'd just like to focus on a number of aspects this morning, if I may. Enhancing public capacity, improving care at primary community level, encouraging innovation, and the multi-annual waiting list plan. Firstly, a critical aspect of Sláintecare is to enhance the capacity of the public health system. Significant investment has been made by the government, and this is delivering additional staff, more hospital infrastructure and capacity, and more activity, unprecedented levels of activity. For 2021, the government has allocated almost 21 billion to core health spending. This is an extra 6 billion over the original allocation in the budget for 2018, 4 years ago, or an increase of over 40%. Priority investments include funding to reduce waiting lists, additional staff, more bed capacity. I know the CEO of the HSE will touch on this in more detail, so I'll just be very brief and give some of the highlights. For example, there's additional critical care, acute and subacute beds that are fully funded and opened in 2020 and 21. Staffing in 2020 experienced the largest increase since the foundation of the HSE, and 2021 has seen that trend continue. with more than 6,000 whole-time equivalent staff numbers recruited across all service numbers. There are now over 12,500 more staff working in a health system than there were at the beginning of 2020. And that's the most rapid increase in staffing numbers over any two-year period, I think, since the HSE was established. And again, as colleagues know, for this year, there's another further significant increase in staffing numbers planned. And specifically, of course, there have been improvements in staffing in our acute services, which increased almost 4,000 in 2021, another significant number, 3,690 in 2020 and 2021. Secondly, significant investment has been made to enhance community care capacity to affect the shift from a hospital-centric model of care to delivering more care in the community. For example, an additional 837 community beds were delivered in 2020-21. To date, 51 healthcare networks, 15 specialist teams for older persons and 2 chronic disease management teams have been established, as well as national coverage of community intervention teams, all targeted at reducing dependence on the current hospital-based system of care. Each community specialist for older people will see between 6,000 and 7,000 people a year, which equates in total to over 210,000 patient contacts a year overall. Chronic disease management teams, when they're fully established, will have approximately 30,000 patient contacts a year, which represents over 900,000 contacts a year on a full basis of implementation. Approximately almost 21 million hours of home care support were delivered in 2021, with over 55,000 people in receipt of the service by the end of last year. This is about 2.9 million, or 17% more hours compared to 2020, with increased funding maintained for this year. Over 85% of GPs registered with the GP Chronic Disease Management Programme, with near to 220,000 consultations delivered in 2021. And finally, the GP direct access to diagnostics, another key element of Sláintecare and debate and discussed for many years, resulted in over 138,000 radiology tests being accessed by GPs in the community. And I understand that a further 17,000 have been undertaken last month alone. On the basis of that run rate, I think we'll be close to, if not above, 200,000 for the year as a whole. Thanks to the efforts of the HSE, these resources not only enhance community care, but avoid unnecessary trips to hospital, free up bed capacity for more complex and urgent cases. Thirdly, we are fostering a culture of innovation through the Sláintecare Integration Fund, investing in new care pathways, new technologies, new ways of working, and attention shifting care to the left and engaging directly with frontline staff. Specifically, the fund facilitates the testing and evaluation of innovative models of care, with 105 out of 123 projects being mainstreamed through the HSE. These projects resulted in over 15,000 reduced referrals, more than 18,000 acute beds avoided, and over 8,000 patients off waiting lists. And more details, Chair, are included in the Sláintecare implementation report, which the Minister published yesterday evening, which sets out in more detail some of the numbers and some of the benefits, very significant benefits of these changes. The National Ambulance Service successfully continued the development and implementation of alternative care pathways with the aim of hospital avoidance and an improved use of healthcare resources. The total patients treated by the NAS Alternative Service was over 18,000, with 44.3 treated at home or in the community. And finally, there have been various e-solutions, e-changes brought about, which are improving the overall efficiency of the system, freeing up staff time, reducing the administrative burden. And we just mentioned 2 of them there. 14 million prescriptions were transferred electronically in 2021, an enormous amount of activity in the community, and enabled much more efficient administrative management of that issue. And there's 333,000 video consultations were delivered based on the estimates that we have. And clearly video consultations, now that we see it can work, will have a role to play in the future. A critical objective of Sláintecare, of course, is to reduce waiting lists. The short-term waiting list plan published by the government in October 21 resulted in a 5.4% reduction in overall waiting lists, which was in line with the target reduction. The 2022 waiting list action plan has been finalised by colleagues in the department and the HSE, and we brought to government next week. This plan will set out actions to deliver further reductions in waiting lists, address backlogs, stem future growth, and lay the foundations for future reform actions. It will set out how and where the additional funding will be allocated. And as members will know, 350 million has been committed to support this plan, 200 million to support waiting list initiatives, and 150 million allocated to the National Treatment Purchase Fund, an increase of over 50 on last year's allocation. And each year, the number of new additions to waiting lists increased significantly, and the challenge is to increase activity, both to reduce the stock of people waiting too long and address new additions. In 2022, this year is estimated that over 1.5 people will be added to the waiting list. This reflects normal additions and an acceleration in presentation due to deferrals caused by COVID. Under the proposed plan, which the Minister and Government hopefully will publish next week, the HSE and the NTF propose to deliver services to remove many more patients from active waiting lists. We estimate that the largest level of activity ever delivered and will result in a significant reduction in these lists. It is hoped that by the end of this year, the number of patients on active waiting lists will be at its lowest point since the beginning of COVID. Reducing waiting lists will also require further capacity enhancements, and ultimately plans are progressing for new elective hospitals in Cork, Dublin and Galway that will cater for up to 940,000 planned procedures and operations each year. And this is a critical change, short-term and medium-term change in the configuration of the system to increase capacity to enable us to increase the number of elective procedures. Of course, reducing lists will also require ongoing change and reform and productivity, improvements in pathways, other issues that Paul Nadal and his team will touch on later. And increasing productivity is a key part of the response to this challenge also. In addition, it will require progress on ensuring that all patients are treated in public hospitals on the basis of need and not their insurance status. This will free up capacity in public hospitals, but also ensure a more equitable system. Removing private income from public hospitals is a key government objective and a key objective of Sláintecare. Will require legislation and further discussions with the representative bodies. Members will be aware that talks have been ongoing with representative bodies on the implementation of a Sláintecare contract, which will pave the way for the removal of private care from public hospitals, and we look forward to further engagement on those talks. Turning now to Sláintecare governance and oversight, a new Sláintecare programme board co-chaired by myself and Paul Reid had been established to drive implementation of Sláintecare reforms. Reporting directly to Minister Donnelly, the Sláintecare board will ensure enhanced coordination for key reform priorities. The board has met twice since December and will meet every second month going forward. And responsibility for the overall project management office has been assigned to leadership of an Assistant Secretary, Derek Tierney. As this committee is aware, our hospital group and community healthcare organisations are not aligned geographically, nor do they overlap in terms of management, clinical oversight or budgets. The Sláintecare report identified RHAs as essential for proper integration, improved integration of the health services and a population-based planning in Ireland. The allocation of resources will also enable better oversight and evaluation of costs and health outcome benefits. RHAs will ensure the alignment and integration of hospital and community service at a regional level based on defined populations and local needs. The government approved the geographies of the regions in the months preceding the pandemic. The government decision directed the department to explore the organisational design, governance frameworks and funding methods via a business case. A memo for government decision is now being drafted, which Minister Donnelly will bring to government in the next few weeks. A detailed implementation plan is being developed by the department and the HSE with input from the newly established RHA advisory group. This will cover how RHAs will impact on workforce, HR planning, funding allocation, capital infrastructure and governance lines. Our high-level timeframe is for design detail for this year, with implementation beginning in 2022. To conclude, Chairman, with the unprecedented funding and support of government, we have a real opportunity now to build on recent progress and to continue to implement Sláintecare at pace and to continue to translate the Sláintecare report from shared vision to reality. And finally, if I may take this opportunity once again to thank all our colleagues in the Department of Health and the HSE for all their continuing work and dedication in delivering on this agenda for the Minister and for the Government and ultimately for the citizens of Ireland. I look forward to working with the committee and answering any questions. Thank you, Chair.
Thanks very much. Can I now call on Mr. Reid to make your opening remarks?
Thank you, Chair and members, and very pleased to present here today along with Robert and his colleagues and our colleagues from the Department of Health. And thanks for the invitation also to meet with the committee to discuss the implementation of Sláintecare. And I'm joined by my colleagues here today, Anna Connor, Chief Operations Officer, Yvonne O'Neill, National Director of Community Operations, Liam Woods, National Director of Acute Operations, and Yvonne Goff, National Director of Change and Innovation. Sláintecare provides with an unprecedented opportunity to bring about sustained improvements in the quality and capacity of our health system. The reform agenda that we're now pursuing has the full support of the HSE board, which will have oversight of our progress in accordance with its statutory governance role. Our primary focus will be improving access across community and acute services, increasing bed capacity, addressing health inequalities and enhancing patient experience. As members will be aware, the HSE Corporate Plan 21 to 24 details a transformation agenda for health and social care and was developed to align with the Sláintecare objectives. In quite an organic way, our response to the pandemic has accelerated many service changes that ordinarily would have required lengthy planning processes. I mentioned, for example, as Robert will have done there, e-health, community healthcare and service integration. These innovations are both enduring and system-wide and were driven largely from the front line, which ensured successful implementation. Models of care were developed in line with one of the principal objectives of Sláintecare strategy, providing care in a location that meets patients' and clients' needs. The pandemic has therefore provided invaluable insights into how we can embed these ways of working, and I'm keen to assure that we use all that we have learned to the fullest extent. A key example of such progress last year was GP access to radiology services.
I'm not asking that question from Care Champions.
With 5 external providers.
You don't have to tell them that.
Say just
you can just say, I'll try and get to it, but I have some questions before that.
Sorry, is somebody coming in there?
Will you put yourself on mute, please?
A key example of such progress last year was direct GP access to radiology services, with 5 external providers seeing just under 140,000 referrals by the year end, thereby reducing materially the demand on our hospitals. Over 2019 to 2022, 210 million has been available through GP agreement 2019 supporting modernisation initiatives, the e-health agenda and the rollout of chronic disease management programme to over 430,000 people. The Enhanced Community Care Programme was allocated 240 million for the establishment of 96 community health networks and 30 community specialist teams for older people and those with chronic disease to provide integrated services locally. 1,400 staff have been recruited, with over 2,000 additional posts to be recruited in 2022. 51 community health networks, 15 community specialist teams or older persons, and 2 chronic disease specialist teams have been established to date. Separately, the target of 91 disability network teams are in place, and these developments are being delivered collaboratively with voluntary providers to deliver enhanced care across general and specialist services. Expanded community intervention teams were further developed in 2021 with 5 additional teams and 3 enhanced teams, meaning that we now have 21 community intervention teams operational. Immediate measures were also taken to reduce hospital and critical care pressures by permanently increasing surge capacity with 324 additional inpatient beds along with 42 additional critical care beds. Additional capacity was also contracted from the private hospitals to support demand. We continue to work with the private sector to rapidly reduce waiting list numbers. A further 314 public community beds and 498 private intermediate care beds were introduced as part of the COVID-19 response. During the pandemic, ambulance service moved away from the emergency medical service to a model of emergency service to a Sláintecare aligned model, reorientating healthcare from the traditional hospital-centric model by bringing care to patients rather than patients to care. Such developments were planned pre-COVID to manage the impacts of an ageing population, chronic disease and growth in our population more generally. As a consequence of the pandemic, this was accelerated. Sláintecare integration funds projects have been established in more than 100 locations nationally with project partners from acute, community and academic settings. Many of these projects have already been mainstreamed, primarily through the Enhanced Community Care Fund, and the HSE welcomes the 4 million provided to support 29 projects this year. Though the HSE delivers approximately 3.3 million outpatient appointments, over 1 million day cases and 82,000 elective discharges each year, demand continues to exceed current capacity in many specialties, and I fully acknowledge that patients are waiting far too long to be seen. During the pandemic, outpatients waiting lists grew by 98,000, 18%. Inpatient day cases grew by 9,000, and endoscopy waiting lists grew by 10,000. Working with the HSE and the NTPF, Department of Health published a waiting list action plan in October 2021, focused on providing additional procedures through public and private hospitals by the end of 2021 to reduce those waiting lists. By the end of December, the outpatient waiting list decreased by 35,000, as Robert said, 5%, with a 21% reduction in those waiting 18 months or over. There was only a slight decrease in the inpatient day case waiting list due to the significant cancellation of elective surgeries due to COVID-19 and emergency department pressures has had, and a decrease of 5,400 in the endoscopy waiting list. A plan to improve waiting lists and achieve Sláinte Care access targets is being developed by Department of Health, clinical and managerial colleagues. Essential to the reform of scheduled care is the concurrent redesign of care in the community. We are also aiming to redesign acute care pathways by engaging, wherever possible, new technologies and innovative service delivery models. Significant progress has been made to modernise and implement over 70 clinical pathways with 16 clinical specialties. A waiting list plan for 2022 is currently in development, and the HSE welcomes the additional funding of 200 million, which will be focused on delivering additional capacity to support this work. The implementation of regional health areas using a population health management approach will significantly impact on the health system. Working with the department, we expect to scope out the design and the development of the regional health areas and to finalise the implementation plan, which is consistent with the government's decision to establish the regional health areas. It's anticipated by the year-end, corporate and clinical governance frameworks will be completed. Aligned to Sláinte Care, regional health areas will support population-based service planning and funding. So in conclusion, Chair, the scale and challenge of Sláinte Care's implementation should not be underestimated, and methods of implementation and detailed planning will be important to ensure our success. Collaboration was paramount in 2021, and it's strengthened relationships greatly with healthcare providers all across the public, voluntary and private and acute community settings. This coalition allowed us to meet the relentless demands of the pandemic. Given what a health service has faced in the past 23 months, the almost instinctive alignment of the system's Sláinte Care principles demonstrate the commitment of our staff and their belief in this hugely important national strategy. I've no doubt that this spirit and collaboration is key to unlocking the further potential and delivery of Sláinte Care. I assure the committee that the HSE will devote the whole of its efforts to ensuring that we deliver on Sláinte Care. Achieving this would be a fitting reward for the public and also for our healthcare staff who've given so much over the past 2 years. And I too would like to acknowledge huge commitment and sacrifices made by our teams over the past 2 years. 5 waves of COVID and a cyber attack is not what many organisations could sustain. Thank you, Chair, and that concludes my opening statement.
Thanks very much to both of you for your opening statements, and just acknowledge the work that, as you say, has been done during the pandemic, the exceptional work that's been done by all the healthcare staff and those others who are being in a supportive role. Maybe just before we bring in the questionnaires, we hope to have these meetings on a regular basis, and I hope that you and your teams can facilitate us on a regular basis. That today's meeting is primarily around the regionalisation and governance, but we hope to on a regular basis have meetings in relation to different aspects of in relation to Sláinte Care and the implementation of that. So without any ado, I'll move. And what? And in person, okay. And in person if possible, yeah. Okay, so we'll move on to the first questionnaire, and it's Bernard Dorkin.
Thank you, Chairman, and I welcome our guests. And at the outset, I would like to compliment all involved in the battle against COVID and for the huge sacrifices they made, their commitment to their duty, and the overall response of the services to the challenges. And no words, I think, can convey sufficiently the public's response to their efforts. So I want you to note that and acknowledge it. I also want you to transfer that energy and coordination and effort and exercise to the next challenge, which is to deliver a fast, efficient, effective health service to the community in line with the objectives of Sláinte Care in the shortest time possible. And I'm anxious that we would move away from the area of a percentage improvement on what was last year's performance. Last year's performance, as the performance of the year before, in areas of waiting lists, in areas of acute services, in areas of waiting in general. We have to move away from that, because people who have a health problem are not happy when they're waiting, because they don't know how long they have to wait, and in some cases experience has shown them that it isn't a good place to be or a right place to be. At the outset, I just want a quick response to 2 issues. CH07 is the area north, southwest Dublin and Kildare, and an area that's densely populated, has huge challenges, is low in the support staff required at all levels. But for example, in the social services and the level to which social workers are deployed in that area, it's non-existent. There's a serious crisis there. It needs to be dealt with as a matter of urgency. And I would cite also the issues in Donegal and in Kerry that have come to public attention in recent years, where there were serious flaws in the system, in the duty of care that the services have to patients or potential patients. And I would like perhaps a quick response as to what's likely to happen in relation to those issues for starters.
Thanks, Deputy. Maybe I'll come in first, and then maybe Paul and his team might answer that specific question, the final comment you made. Just generally in relation to your comments in relation to the staff in the department of HSE, I will certainly communicate that back to staff, and I know Paul will do likewise for his team, and it's very much appreciated the recognition that people receive for what has been an enormous effort over the last 2 years, and I'll relay, Deputy, those comments back. And I agree with you about the need for us to galvanise much of the spirit and intent and ways of working during COVID to the challenges, more structural, long-term challenges that we have within the system, about enhancing capacity, about improving clinical outcomes for people, and addressing the question of waiting lists. And absolutely, and that's what myself and Paul and our teams are now focused on, and thankfully able to focus on mostly full-time, as COVID is less of a challenge for the health system, but less of a challenge for society. Of course, it's not totally defeated. I should just say that at the outset. We're not going to talk about it today, I know, but and there's still a lot of people in hospital. I think almost 600 people with COVID, and it's still out there in the community. But of course, the more acute phases that we've gone through over the last 2 years, thankfully, we're not suffering from those now. In relation to waiting lists, and I agree, Deputy, with your comment, and I think there is a tendency, and certainly the way I look at things and write speeches, and my colleagues write speeches, we compare, changes in year on year. And if we have an improvement in waiting lists during this year, which I hope we will do, that of course it's no consolation to somebody who is still waiting too long, or is uncertain about when they will actually receive treatment. And this week and next week, the government next week, we hope, will deciding in terms of the waiting list plan, and that will set out a variety of actions to buy more private sector capacity, to drive more public sector output, to change the way we're working, and so on, to increase the overall level of activity. And we hope for this year to have the highest level of activity, waiting list related activity, delivered by the HSE, the NTPF, the public and the private system we've ever had. But of course, even with that, we're still going to have a large number of people at the end of the year waiting, and some of those will be waiting too long. And that represents a challenge. And after this year, the challenge for us will be to do even better in 23 and make further improvements, which will involve more resourcing, more capacity, and different ways of working. And I think that different ways of working, which Paul in particular set out in his presentation, I think is absolutely critical. You can see some of the enormous benefits and some of the improvements in terms of people, deferrals, people not having to go to hospital avoidance, and so on, from some of the changes. But absolutely agree with you, and that's what we're fully focused on.
Can I ask, before Mr. Reid comes in, can I ask, there were a number of concerns expressed by the coordinating team previously in relation to the phasing in of Sláinte Care, and those resulted in resignations. Have their concerns been addressed, and are they being addressed, or have they been fully addressed?
Thanks, Deputy. Yeah, so there are obviously last year a number of high-profile resignations, and I think I was at the committee talking about those at a previous occasion. So we hopefully have learned the lessons from that. We have a different approach now, where the key projects under Sláinte Care have been delegated to senior leadership nomination in health and in the HSE, and they're working together now, implementing that. And there's a board established under the chairman, myself and Paul, and we pull that together. And beneath myself and Paul, and beneath that overall board, there's very significant activity every week by the teams pushing ahead. Paul and I will review, Deputy, this structure in mid-year with Minister Donnelly, and we see is it meeting our needs. But ultimately, it's about
are they being addressed? Are they being addressed?
Yeah, I think No, I think they have been addressed. Yeah, Deputy, I think they have been addressed, and we're very committed to having the right structure. But ultimately, it's about focusing priorities on the key projects that can make a difference and driving that change. Some of these projects are very challenging, and the RHA, which I think we're going to discuss sometime this morning, is a very difficult project involving very significant change. There are other aspects of the reform agenda that are easier to deliver than others, and we are making more progress on some than others. Are clearly enhancing public capacity, moving care to the community. Paul and I have touched on that this morning. We're making very significant progress there. Less progress, of course, in other areas. But no, I'm happy, Deputy, that we've addressed those. Obviously, Paul can give his views now in a moment, but I'm happy that we've addressed some of those concerns that did exist, and we have a structure that can help us implement this agenda.
Thank you. Reid.
Yeah, thank you, Chair. Thank you, Deputy. And I just come in behind Robert on a few points. Just first of all, I will relay your thanks and thank you for making those comments. We'll relay them back to teams. It does make a difference. Just specifically related to the general point which you've made about embracing the pace and agility that's been demonstrated through the past 2 years. I share your appetite that we do embed that now going forward. And just a couple of things that I would take, probably 3 things that I would take from the past 2 years that we need to consolidate in terms of ways of working. The first one was a much better understanding of what value is added from the centre of the HSE and what is added from the services. And that is a core principle of Sláintecare. So, for example, we focused on some of the national issues around whether it's PPE procurement, whether it's testing and tracing or vaccination, and let the services get on with reform and driving reform because they know best and they can do it best on the ground. And I think that's something we have to unleash ourselves and embed stronger in the next couple of years as well. So that's one learning. The second learning I would say from the past 2 years is decision making. I think for far too long, we take too long to make decisions and business cases and PowerPoint. And certainly I know with Robert, we're committed. You know, we used the principle during the past 2 years. If it's 70, we will probably get 70% of our decisions right. And I don't just mean from a clinical perspective, but in terms of driving change. And we have to learn from the other 30%. But what we can't do is wait for perfection at all times. And certainly the principle we're bringing into the next phase of change is to go, if we're 70% something, we're 70% comfortable with something, it's probably good enough to go and let the system go at it. So I think that's the second principle we want to embed. And the third one, which is absolutely aligned with Sláintecare, which is the whole issue of moving the services to protect the acute hospital system by increasing our services in our community. And we can give some good examples in our opening statements, but, you know, community health networks, community specialist teams, access to diagnostics or GPs, primary care facilities and staffing. The couple of other points to just say, and one of my colleagues might specifically comment on CHO7, but you have touched on something which is a challenging issue in terms of recruitment, but just give you a very brief scale on it. Over the past 2 years, we've recruited actually over 35,000 people. We have to recruit 9,500 people every year to stand still in terms of natural churn. We've 132,000 people now in the HSE. It's a net increase of 12,500. As Robert said, the biggest increase, unprecedented. And on top of that, we've had to about a further 4,000 people who are on testing and tracing and vaccination programs. Now, if you look at the mix of that, and I won't go through it all here, but I think for once, we have actually got a very good mix across that 12,500. If you just look at over the past couple of years, 3,300 of those come from nursing and midwives professions, 2,100 actual staff nurses and midwives, almost 2,000 healthcare assistants, 360 consultants, patient and client care, 2,300 people who are at the front line, whether it's healthcare assistants or national ambulance staff. So we do have difficulties in some areas, Deputy. I fully acknowledge that, particularly in some of the areas you've referenced in South Kerry and Donegal. And that is an issue for us in terms of recruitment of specialists that we need in those areas. Generally, what we are seeing is professional consultants in particular want to move to the big urban centres and want to be based in the big urban centres. And there is a quality of life that we're trying to promote in our recruitment process for people to work a little more.
This is something, Mr. Reid.
Bernard, you're out of time. I need to move on to the next person. Apologies, we're really stuck for time this morning. So again, I'm asking witnesses to try and keep your...
What time slots are we, Chairman?
You got 10 minutes?
10 minutes, okay, sorry.
Okay.
My apologies. There are a number of questions there I will take written answers to.
Okay, thank you.
Chair, just a point of order. My understanding was was that this meeting was specifically to be about the oversight structures in relation to Sláintecare and specifically regionalisation. I just wonder, could our guests stick to that agenda?
Well, again, if they're asked questions outside the remit of it, but
maybe members could as well, because this needs to be a productive session.
Okay, thank you. Right, we're moving on to David Cullinan next.
The speeches of the opening speeches.
To people with disabilities first needed in our housing sector. When we're building housing, we need to ensure that there is a proportion of every development.
Okay, we're moving on to questions now. David Cullinan.
Okay, welcome Mr. Reid and Mr. Watt, and I want to keep on the topic of Sláintecare and regionalisation. I will have some questions later in relation to recruitment, because the three areas that those who resigned from Sláintecare gave, or the three reasons they gave for their resignations, were a lack of movement as they sought slow progress in regionalisation, the establishment of the regional health areas, e-health, ICT and financial infrastructure, and waiting lists. So I want to start with regionalisation first. And Mr. Watt, you said that lessons have been learned and a different approach is now being taken in relation to Sláintecare when you were asked about those resignations earlier. Can I read to you, Mr. Watt, an email that you sent to Mr. Reid on the 24th of September 2021? And this is a paragraph from that email. I agreed with the conclusions that we reached to defer implementation given the pressures we all faced. Having reviewed the papers, I also agree that structural changes need to be kept to a minimum and reflect the reality of your reorganisation, as in Mr. Reid's. Specifically, all corporate functions, clinical care pathways, work, etc., would remain the remit of the HSE as they currently are, and that there would be no vertical reorganisation. Now, I have to say my heart sank when I read that, because what that tells me is, one, no vertical reorganisation is let's keep power and control in the centre. Two, if we're not going to see corporate functions and clinical care pathways and so on a real part of reform in terms of the regional health areas, we're not going to get structures that will work. So can you first of all, very quickly, Mr. Reid, explain to me what you meant in that email? Sorry, Mr. Watt.
Thanks, Deputy. I don't have the email in front of you, but I think I recall it and what your summary sets it out. So I think Sláintecare itself, the division set out in 2017, said that any structural changes should be kept to a minimum, and the minimum required to deliver on the overall objectives, which is get better geographic alignment between the CHOs and the hospital groups, and also to ensure integration of care at local and regional level, and to ensure that resources are allocated based on population needs in those regions. So there's high level objectives. So we're very conscious that we need to keep structural change at a minimum required initially to deliver on the objectives, because structural change is very, very time consuming, can be very disruptive, and we have very busy organisations, very busy teams that are delivering care as we go along.
If I could just come back in, Mr. Watt, I've heard what you've said. It doesn't chime at all with what Sláintecare promised, and it doesn't chime at all with what those who actually resigned from Sláintecare wanted, and it actually does chime with the reasons why they left and the reasons they gave. You can't say that in terms of making the changes that there will be no vertical reorganisation and then say we're going to see substantial reform. You can say that corporate functions, clinical care pathways work, which is central, will remain at the centre, will remain within the HSE as they currently are. That to me says more of the same, keep it as it is, superficial changes, which is not what we need. You talked earlier about the unacceptable wait times, almost 900,000 people waiting. We have elderly people, as you know, on trolleys, 1,100 of them in January, over 24 hours in acute hospitals. They need change in healthcare. And it's not just about structures, it's about resources and capacity. But when I see things like no vertical reorganisation, keep things as they are, keep things as they currently are, that doesn't tell me that we're going to see the reforms that we need.
Yeah. So I don't have, Deputy, the email in front of me, and I can't recall every single word and every single sentence of what I said to Paul. But from recollection, what I think I was trying to say, and I think Paul summed this up well earlier, that there's national strategies, national objectives, things done at a national level. And then there are things that are done at a local or regional level, and we need to ensure that the structures enable the centre to deliver nationally in all the different ways that Paul has touched on, but in order to ensure that the regional local structures then enable people to reform and change to deliver, because they know best on the ground how to deliver those care. And what I meant, I'm trying to recall back, what I think I meant by the email, and maybe it should have been worded better, is that initially, we're not going to focus on a significant restructuring of the centre or transfer of responsibilities currently undertaken at a national level or a centre to the regions. The focus is more on the horizontal integration.
Okay, I have that. I have what you said, Mr. Watt. We have very limited time. Very limited time. I've had what you said. Sure. Oh, can I ask then in relation to I gave you a lot of time to respond, in fairness. No, in fairness, I gave you enough time to respond. I just want to come back in relation to, this was basically was referring to meetings or conversations that you had with Mr. Reid. So I suppose the question then is, if you're saying, and you say maybe you could have worded it better, that structural changes need to be kept to a minimum, they need to reflect the reality of your reorganisation, as in Mr. Reid's, that corporate functions, clinical care pathways would remain in the HSE as they currently are, and no vertical reorganisation. Is that the Minister's view, or is that your view?
So I don't think I share your characterisation of the letter. So I didn't say that there'd be no change or the change wasn't required, quite the opposite. But we're having a discussion, a reasonable debate and discussion, which I think people would expect Paul and I to have, about what type of change initially may be required to deliver what we want to see. And I think the point I was making is that I didn't think I saw that the initial objective was a significant realignment of functions between the centre and regions. That's what I meant by vertical change, and that the focus is more on integration at a regional level, the horizontal change. In terms of Minister Donnelly, obviously I don't speak for Minister Donnelly. You have plenty of opportunities to ask him questions, Deputy. But yes, Minister Donnelly is in favour of delivering RHAs. He has set up an advisory group to advise. There are many different questions that we have to address in terms of how this will be done, how quickly it will be done, the phasing of it, and Minister Donnelly is well aware of the work that's proceeding, and Mirish O'Connor, my colleague on the call,
I have to come back in. Okay, Mr. Watt,
Minister will bring in a memo to go.
I have two other questions, and I want to, no, Mr. Reid, I have two other questions, and I will come back to you in a second. We have very limited time, and it's my time, and I want to put the questions that I'm prepared for. Can I ask Mr. Watt in relation to the recruitment target within the HSE? So there was a target set to recruit 10,000 staff this year in 2022. In your view, Mr. Watt, are we going to reach that target?
So I think we've said, I think this has been subject of that the minimum target is 5,500, which I think will be the third highest recruitment year ever, and that the stretch target is 10,000, which I think we all acknowledge is going to be very, very difficult to meet, given the recruitment.
But I'm asking you your view. Do you believe that target of 10,000 will be reached this year?
I think it's going to be very challenging to reach that target. Very
challenging, but is the resources, is the target of 10,000 and the financial resourcing of that going to remain in the HSE service plan?
So the service plan is based on 10,000, and for the moment that money is allocated to that subhead. But as ever in health, during the year, if it transpires that we're not in a position, and if the judgment call ultimately is that we can't meet that target, well then the Minister can give a direction to Paul and his team about reallocating that money to ensure it goes to...
Okay, and I have a question then for Mr. Reid. And Mr. Reid, this is a very specific question that requires a yes-no answer and then an amount. Is there going to be a prior year adjustment of HSE accounts for the year 2020? And if the answer to that question is yes, how much will that be?
Chair, and I know you like the yes/no questions to me, but what I'm going to have to say on this one first, and I do want to make two very brief comments on your previous questions. On the prior year adjustment, if there is to be one, we're still working through a process that will determine if there is to be one or not. And that's a process that we're working through with the department, with the Audit and Risk Committee of the board, and our board overall, and indeed the CNAG, should we have to move towards process.
Is the answer that you don't know, Mr. Reid? Have you an estimated amount of what that will be?
Yeah, with respect, Deputy, I'm trying to answer your question. In terms of what the scale of that might be, we estimate at this stage it will probably be less than 100 million. It's not an increase in funds. It's a technical adjustment, which ultimately is a reduction in funds, but it's a technical reduction.
Will it be greater than 90 million?
Sorry?
Will it be greater than 90 million?
Yes, yeah.
Okay, so somewhere between 90 and 100 million. Why couldn't you just said that then?
Chairman, sorry, Deputy, I'm trying to say to you, it'll be less than 100 million from what we judge right now. It's a process that's ongoing. It's a scale, it's an assessment of €1 billion of provisions and accruals for the end of 2020. That's the scale of what we've assessed. And we initiated that review jointly with the department. So my judgment right now is it'll be less than 100, probably greater than 50, but I can't be very specific. And if that will determine should we need to do it at all. Can I just make two very brief comments just on two very brief things, Deputy, if you appreciate it. Just on the regionalisation, I would ask you not to make too many early judgments just based on correspondence between Robert and myself, specifically related to corporate functions. There's no doubt there will be HR and finance functions in the regions. They'll need them and they should have them. What we were having an exchange about and what is the core principle, there will be some things that are best held at a centre, and clinical standards and clinical guidance is one that we do and will need consistency across regions in the future. But I would say to you, I'd urge you not to take too many judgments because we're still in the design phase of what that might look like, and you will quite rightly probe it strongly when we get to a better stage on that one. And just secondly on the recruitment, just because it is a very topical one, as my colleague Robert said, two things on this. Number one, we are targeting to recruit 10,000. I have a role as a public servant, which I respect hugely, and Robert does as a civil servant, Secretary General, to advise the Minister and advise government if we see a jeopardy at any early stage in the planning process. And based on what we've done for the past 2 years, we see not just a health recruitment market, but a recruitment market under significant stress, and particularly in health sector, a global market for it. So we did flag up through the department, through the Minister, that yes, 5,500 would be our likely projections, but we do, and we'll be pulling out all stops to achieve the 10,000. And just on that, positively, in January, we had 675 net recruitment people in.
And the 300 in mental health?
That's
the 300 in mental health, will they be recruited this year?
That's what we're striving to do. And as you know, Deputy, this is a really difficult market. If we knew the market had all that capacity, I would be saying we'll do 10,000. But I'm saying up front, because it's my role as public servant, the market isn't showing that capacity there. But we'll be striving, particularly on mental health. It's a big gap we have and we want to achieve it.
Paul, I need to move on, Paul. Gino Kenny's next.
Thanks to all our witnesses here today, and I think the last 2 years have been the last 2 years have been completely unprecedented in relation to the pandemic, and I think it's probably a time of reflection on how we treat our healthcare staff in hospitals and how public health is delivered. And them 2 years, I think that is time for reflection. And as the pandemic recedes, the fault lines re-emerge in society. And the fault lines that I think have defined this country in the last number of decades has been public health in relation to hospital waiting lists and so forth. So there's obviously a huge issue in relation to reform and regionalisation of the healthcare system. And what most people will, when they're listening to this programme here today, most people will want to hear in relation to public health, or whatever you want to call it, Sláinte care, will it deliver for them? And will, in relation to elective surgery, seeing a psychologist, will it deliver for them? So can you reassure the public that Sláinte care in the immediate and long term will deliver them reassurance to the public?
Chair. Sorry,
Deputy, maybe would I go first, and then Paul might come in. Then, thanks, Deputy, for your comments at the start. My view on this is that, and as Paul and I have set out this morning, and as we set out in a report that the Minister published yesterday, I think Sláinte care is delivering now. It's delivering significantly in terms of reform and the level of activity that has been delivered by the system. So it is delivering, and it will continue to deliver into the future. But of course, there are structural problems within our system structural problems in relation to capacity within the public system, which gives rise to, as we're debating this week, issues around trolleys, and there's a significant issue around structural issue in terms of waiting lists, where public patients have to wait too long for treatments. But a key objective of the plan is to address through a whole variety of different actions to address those concerns and to improve the performance of the system. And that's what we're doing. And I can definitely say, Deputy, that our focus is to continue to improve the performance of the system. Can any of us give guarantees that we will have no waiting lists or people not waiting on trolleys? No, of course we cannot, given the change in our demography, given the change in demand. But absolutely, I'm confident that we are delivering, and with the support of the Minister and the Government, we'll continue to deliver for patients and for our citizens. Thank you.
Very, very briefly, Deputy, just I fully share your concerns around what the public will receive and how they will receive it in the coming years in terms of their care. And I do believe during COVID, the public did get a better level of trust and confidence from the health system for a number of reasons. I think we operated as one more integrated health system than the public would have experienced in many times in the past. And what I mean by that was all elements of the health system coming together, whether that's GPs, pharmacies, the statutory hospitals, non-statutory hospitals, private hospitals, the department and ourselves, working in a more coherent and collaborative manner. I think that's what the public expect, and we need to keep that going. But specifically, they will judge us on what their experience is in coming through. And I think we need to be honest, as Robert had says, there is not an immediate short-term fix, but we have to focus on some of the priorities. The waiting list most definitely is one of our priorities. What's probably not publicly understood is we do over probably about 3.4 million procedures per year, but we do have about 800,000 or so of waiting lists, and there are people waiting far too long. And we took an approach, very briefly, Deputy, just to give some level of reassurance, in the period September 21 to December 2021, with a joint approach chaired by Robert and myself and our teams, looking at all aspects of public health delivery, private capacity, NTPF, reporting, hospital groups, specialties. What's the 80-20? Which specialties can we concentrate on? How do we focus on the longest waiters? And that's a process that we're going to continue into the multi-annual waiting list. But I do want to be honest with the public and yourselves, Deputy. It's not a short-term fix. It is a multi-annual fix. When I took up this role, I'm sure when Robert took this role, we didn't take it up on the basis that we will solve this in a year or two. And we certainly didn't take it up, with the impacts we've had to deal with COVID. But we're focusing on what the public expect from us.
I think I do agree that we've seen a glimpse of what could be in relation during the pandemic, where there's no such thing as a two-tier health service. There is one health service that delivers for everybody, and we've seen a glimpse of that. And hopefully, I think the majority of people in this country would want to see that service provided for everybody, regardless of your outcome or your income. Just my final two questions is in relation to the Sláinte Programme Board. What is the composition of that board in relation to personnel?
Thanks, Deputy. So Paul and I chair the board, and then our colleagues from the Department of Health and the HSE, senior colleagues, are on the board, and others come in and out of board meetings depending on the topic that's been discussed. So there's a number of us who meet every second month, but there are others then who come in and out, and Caroline is on the call, is involved in convening that meeting, and Jack and others involved in the planning of that. So in effect, it's the senior leadership team, both in the Department of Health and the HSE, supported by our colleagues throughout both organisations as necessary.
And how many members would be on that board?
I think about a dozen, Deputy, but I can check with you.
Okay.
Yeah,
if
a dozen.
And could
sorry,
you name?
I just add very briefly, Deputy, sorry. Yeah, just equally as Robert said, from my own perspective at HSE, we have the most senior lead national directors on it who are here with me today. So the Chief Operations Officer, National Director in Community, National Director for Change and Innovation, National Director for Acute Hospitals. And as Robert said, we would, based on the item presented on the day, we will bring in other key leads. And I would just make one very brief point, because I know the whole core of today's discussion is on governance and structures. I've been involved in reform and restructuring and realignment across my whole career, and I think where it works best is where the senior team own it and are responsible and design it and drive it. And I think that's a model that we have. We get the space and time to make it work.
Is there any member of any of the trade unions in the health service on the board?
No, definitely not. No.
Why is that?
There's other fora, a deputy, both the Department of Health and the HSE, where we engage with representative bodies, both formal fora and informal, and that's what we do, and we're accountable to the government and, of course, to committees, this committee, for delivery of that. But when it comes to matters of staff engagement, there are other structures that we've in place, comprehensive structures which enable us to go about our business, working with various representative bodies.
Okay. And just my final question, and I don't want to kind of personalise this, but Mr. Reid and Mr. Watt, your combined salary is over €700,000 per year. It's an absolutely colossal amount of money. And that equates to 18 nurses' annual salary. Do you think you're worth that colossal amount of money per year, while people are waiting over, in some cases, years in relation to the most basic of public health? Chair,
I'm happy to go. If I'm happy to go answer the question, if that's okay. Look, thanks, Robert.
Going down this road, it's supposed to be around governance, but I'll allow the question if you want to answer.
Yeah, look, Chair, Deputy, my salary or remuneration package was not designed for me or by me. I went into a very open public competition, and I know Robert will let Robert speak himself, but I went into a very open and public competition, and which I understand was an international competition and was the successful candidate. And that's the process I've walked through. So it's not a salary designed by me or for me. And of course, it's a very significant salary, and I take it, I take my roles and responsibilities very serious, and I will work within my contract to the best ability that I can to deliver my responsibilities to the Irish State Republic. Thanks.
I'd like to thank John Lahart for letting me in before him. Thanks.
Robert, do you want to come in now?
No, thanks, Chair.
Okay. John Lahart.
Thanks, Chair. And take my appreciation for the two organisations. I've expressed it before, so rather than taking up time, it's not meant to be rude. Just want to get into the questions. Just in relation to the Sláinte Care Implementation Board, maybe Robert could take it first and then Paul. Cynics could be forgiven for thinking that you've replaced an independent oversight board with the chief executive of one organisation and the secretary general of the department that would have been the subject of scrutiny of that board, and you've replaced that board with yourselves, kind of essentially. And just knowing the way structures work, you're both the bosses of your organisation, and I know you have the heads of this and that and the other on the board, but you are both the bosses. So you could understand, I'm just giving an opportunity to assuage maybe the justifiable cynicism that, okay, they've taken control of this, so actually, you know, you did reference the Oireachtas committee here. All we do really is get 10 minutes each. We don't get a huge amount of time to delve right into it. I'll put my hands up and say I just completely lack the professional expertise to delve into it. So who are the kind of oversight critics with a small c, who provide the critique that the public need to know that this is working properly? So maybe Robert first.
Thanks, Deputy. So I think the previous board was an oversight board. This board that Paul and I have established is an implementation board, so we're focusing on driving the implementation. And the approach that we've adopted, and this is based on my experience in the civil service and outside the civil service, and I've been now working for almost 30 years. Paul has though he doesn't look at even longer experience of change than I, and based on my judgment and my experience at this board that we've established, which is an implementation board, provides us with the mechanism to drive these changes. But of course, we'll review it during the year with the Minister, and if it's not working, we'll change it. And in effect, what we've tried to do, Deputy, is allocate very clearly to the large projects that we have senior responsible officers both from the HSE and the Department of Health, and they're driving the change and their teams, and then they are responsible and accountable ultimately to myself and Paul as co-chairs of the board, and in turn then Paul and I are accountable to the government for the implementation. So that's the board that we've established, which is an implementation board rather than an oversight board. There has been debates on and off about the extent to which we'll have external challenge involved in this, and the Minister has set up, for example, a HRA advisory group which has a large number of external people to help and advise, and we're open to considering whether some other oversight or external function could help. But for the time being, we're happy with the structure, Deputy, and we think it's working, but of course we'll review it, and if people are concerned about the pace of implementation or failings in implementation, then Paul and I will address that, or the Minister or the government will address those for us.
Thanks.
Yeah, just briefly, that Deputy, to your question, I fully understand why the Oireachtas Committee will ask and what oversight, because we are public organisations. To just reassure you in a few points, first of all, we have a board in the HSE that I can assure you hold ourselves in the HSE a very strong account on all aspects of performance and change and reform and delivery to our corporate plan and delivery to Sláintecare. So that's certainly one strong governance within the HSE made up of individual experts. Certainly, obviously, as you just mentioned, the Oireachtas is another avenue, and as Robert said, some independent bodies around the RHAs, the regional health authorities. I would just make the final point, similar to Robert. I think the model that we do have, and it can come under any levels of criticism or scrutiny, I think the model that we do have, as I said earlier on, does give the ownership, does give the accountability. And as I said earlier on, I have been involved in change and reform in private sector, not-for-profit sector, central government, local government, health service. And the only way I've seen it work effectively is people who are going to manage the change, or design the change, are involved in it and accountable for it. And I appreciate this is a public body and needs oversight, but I think we have a very strong oversight.
So you're up and running now. Thanks for that. I know it's only for a very short period of time, and you said you believe the structure is working. I'll go back to Robert first on that. So can you give examples of how you believe that the structure is working?
Thanks, Deputy. I guess it's in relation to the progress that we've set out, and hopefully myself and Paul have given people a flavour of the progress that we're seeing and the number of different issues. But I'll just give you one example of it, the waiting list initiative and the multi-annual plan. So we've been working intensively on this plan. Our colleagues have been working on it. Some of our colleagues who are involved are on this call, and that's filtered up to myself and Paul, who give overall guidance, and then that goes to the Minister. And I personally think the waiting list plan is probably the most ambitious plan that we've developed to increase capacity and increase activity. And that's just one example of it. I think what we're trying to do is continue to develop a good working relationship between the different teams. And from what I'm seeing, that's happening. Colleagues are working together. Colleagues are galvanised and motivated. And it provides the teams an opportunity to work literally every day, every week on their projects, and then ultimately escalate them to Paul and I, escalate them to the board if they have any issues, if there are problems, if there are blockages, that we can then make decisions or provide guidance to try and unblock issues. So it's working. I think the multi-annual plan, which I hope the government will publish next week, certainly the government are considering it next week, and hopefully they'll publish when they're ready. I will give an example of how we're working, something which has been there as an objective for some time, but I think we've got to the stage now where we have a very detailed plan. So that's just one example of it, and I hope that we build on that this year and future years.
Paul?
Apologies, look, I don't have a lot. Just to say that we haven't been waiting for new structures to be set up, and I appreciate the controversy after resignations, but we haven't been waiting for new structures to drive the reform agenda and drive the Sláintecare agenda, because I passionately believe in it. And I know I've been challenged before, I passionately believe in it. So a lot of the change that's happened during COVID, and my colleagues are here today, have led it with the services. That's the right thing. Community specialist intervention teams in the community, GPs having access to diagnostics, community health networks, new roles for National Ambulance Services, pathfinders. These are all Sláintecare. Much of them, were on PowerPoint, were on good plans. They've been put into action. So I think that's the demonstration of the organisation's drive on it. In terms of the new structure, we've had a few engagements, two formal meetings, but it's not just about the formal meetings, it's about what happens between the meetings that we drive.
Okay. And obviously that very much depends, as we've seen this week, on what happens on the ground, but I think that's for another day. I'm just wondering, I suppose we can come back to it, is about your reach into the very, very real depths of the organisation from way up on that structure, and that does come to the regional piece. I do want to be our devolving powers. I mean, I don't want you to answer this because I have a local question, but I mean, how do you from Dublin reach right into the local piece and ensure oversight and ensure delivery? I just don't know how that works. But I have a particular local question. Obviously, Dublin Southwest, my constituency in Tala Hospital, Tala University Hospital. Just the rollout, it's in relation to the under Sláintecare disabilities has been restructured with the introduction of the Children's Disability Network teams. In CH07, Community Health Area 07, that rollout has had a rough enough start with poor communications with parents and a major shortfall of clinicians. So as those waiting lists grow longer, how is Sláintecare going to address the staffing of these teams, you think? Who will you assign that to?
Chair, I'm just going to ask my colleague Anna Connor to come in. Can I just make a brief point as a pass across to Anne, just about reaching to local levels? And Anne and her colleague Liam Woods here are in Cork and Kerry tomorrow, right at the depths of hospitals and community services. So we do, take our responsibility role of getting under the bonnet and working closely with services. But I might just ask my colleague Anna Connor to comment specifically on the disability networks.
Definitely high. So yes, and I mean the area you're referring to obviously has a very high level of demand in terms of children's disability services, and the rollout of the children's disability networks, it hasn't been all smooth. It is a change in terms of how we do our business, no doubt about that. Just in terms of that area, we know at a wider level, if you look at the whole enhanced community care, they're the area that have had the highest allocation of resources. So I think about 495 posts into that CHO to support some of the initiatives that we're talking about here, which is higher than anywhere else. I think the communication, and certainly, with the disability networks, we know that there are, people who are concerned about how they're being developed. It is a change in how we do our business, but we remain very clear that in order to meet the needs of as many children as possible and to do it properly, this is absolutely the right way to go. And we will continue to communicate at a local level. So the networks, we have now commenced all networks, so it took us longer than we had envisaged because of COVID and some other reasons, but we have now got all networks in place across the country for children's disability networks, and likewise we're developing the enhanced community care network, so we have 51 of those in place. So they will work together to really meet the needs of local populations. And I think just linking it to what you said there about the reach, by having these networks in place, we have, I suppose, a structure that allows us to work with people in their local area, really trying to address their local need, instead of looking at everything through either a bigger regional or national lens. Ultimately, it's about the people working in those areas, and we are challenged in recruitment, there's no doubt about it, in terms of being able to secure sufficient health and social care professionals, particularly for those disability teams, to be able to deliver all the services that we want to. But we remain very committed to that. And we're continuing to support all of the CHOs in terms of their recruitment to really kind of continue now to drive the implementation of the networks that are now all in place.
Okay, I need to move on to the next question. Thanks, Oisin Sharto.
Thanks, Chair. I'd like to welcome our visitors. I think it's important to point out just at this point that we're now just coming to the end of year 5 of what was supposed to be a 10-year reform programme under Sláintecare. And I have to say that when it comes to regionalisation, I think the system has stalled, if not that it's gone backwards. And my heart sinks too, listening to the two presentations this morning in relation to regionalisation. Mr. Reid spoke about the senior management team having to own and drive reform. I don't see any evidence of that here this morning at all. There's no sense of, driving a reform programme. What we're seeing, I believe, is capture of the reform programme. And I just want to support my contention that that's actually what's happening. In 2019, the geographical regions were agreed for the regional structure, and the map was provided. That was 2019. They were announced by then Minister Harris, July 2019. Last year, in the Strategy and Action Plan, we were told that, with the geographical areas agreed, a business plan was being produced. And then we needed to address the issues of clinical governance, corporate governance and accountability, population-based approach to service planning, and integration of community and acute services. So I was hoping to get an update from you this morning in relation to those areas, what preparation you were doing in relation to accountability legislation, and also in relation to population-based approach to the allocation of resources. However, when I looked at the email that Deputy Cullinan referred to earlier, I see then in the following paragraph that you, Mr. Watt, are talking about expanding the remit of hospital groups to include community services. Now, a person who makes that statement just doesn't get what Sláintecare is. That's not what Sláintecare is. The hospital groups will no longer apply. These are the regions that have been agreed by the last two governments. And these are the regions that you are required to operate to. But all of the indications are that you are seeking to rework what government policy was and what was provided for in Sláintecare. So what do you mean by expanding the remit of hospital groups to include community services, Mr. Reid? Because that is, Mr. Watt, because that is nothing to do with the regionalisation plan as set out in Sláintecare.
Thanks, Deputy, for the question. Maybe the wording of the email could have been better. So what I understand it to involve is integration at a regional level.
Another letter. When it's the principle of what you're saying. It's expanding the remit of hospital groups to include community services. I think we're all concerned about the fact that, we have a hospital-centric health service. You referred to that earlier. Mm-hmm. So what are you talking about expanding the remit of hospital groups? Can you just explain what your understanding is of regionalisation?
So I think we've spoken this morning about moving away from the hospital-centric system and not only talking about it, but we've set out, I think, in quite detail the enormous changes that are taking place, the primary care centres that are open, the community teams that are put in place.
Mr. Watt, sorry, will you stick to the question I asked you, please? Why would you suggest expanding the remit of hospital groups? What's your thinking on that? I need to be allowed to
answer the question, Deputy.
Please do.
You asked the question.
Yeah, please
You're
answer.
You're allowed to ask the question, and I'm allowed to answer the question. Okay? You don't get to ask the question and answer them. Okay? So
no, I'm not.
What I meant by
I'm
that
asking
was,
you to answer the specific question I asked Mr. Watt.
So what I meant by that is to have integration. So it's not extending the remit of hospital groups is probably the wrong way to put it. It's establishing a new structure that will encompass the fuller range of services at a regional level.
So what's your understanding then? Sorry, time is short. What's your understanding then of what would happen to hospital groups in a regional structure?
They will be subsumed into the new structure, structure.
Sorry.
So the new structure would encompass the full range of services across all the different.
The structures that have been agreed, the geographical areas, are entirely different to the hospital groups. Mm-hmm. So why would hospital groups arise at all? We should be talking about hospitals, not hospital groups.
Sure. Yeah, sure. That's true. So there had to be an alignment, obviously, between the existing structures would have to now be aligned with the new geographies that we've set out. And so the new structures would need to reflect those new geographies. So in effect, there will be a new structure, regional health authority, which would subsume the activities of the CHOs and the hospital groups. So this new entity will be completely different.
No, but you're repeating that. There wouldn't be hospital groups. And there'd be a realignment of hospitals.
I think I said that the new structure would subsume the hospital groups and would subsume the CHOs into a new entity that would provide care across the full spectrum, all the way from community to hospitals.
What you would appear to be talking about is hospital groups subsuming the CHOs and the community services.
I think we're looking at new entities here, and I understand that the boards
what do you mean you
of the
think?
hospital groups that we.
What do you mean you think? There are new entities proposed. They've nothing to do with hospital groups. So do you understand actually what's contained in the Sláintecare recommendations?
Absolutely. So it's a new entity that would carry out now the functions that are carried out by the existing entities, which would be collapsed and which would cease, and there'll be a new entity that would provide the integrated care right across the piece. But that's my understanding of it.
Sorry,
and then we would have then. Am I going to be allowed to answer any question? Like, is that? Am I not allowed to answer any question? Fine. I'll try to answer your question now. Several times.
It is extraordinary, Mr. Watt, that just a few months ago in September, you were talking about expanding the remit of hospital groups to include community services. And that, I can only come to the conclusion that you don't get Sláintecare and that you don't have any understanding of the regionalisation structures that were proposed, which are a central element of the reform programme, and indeed which we were told last year by Laura McGahey and Tom Keane that this was one of the main reasons why they resigned, because there was no appetite in the Department of Health or the HSE to actually restructure and devolve power and introduce legal accountability for the provision of services. And I can't help but seeing now and understanding fully the reasons why those two people resigned. I want to ask you, in relation to that document...
That's a complete mischaracterisation
in relation to
what I said. Completely mischaracterisation.
I can only come to conclusions based on what I'm hearing from you this morning and what I read from you in an email just last September. So I'm going back to the, excuse me, I'm going back to the...
what I said in the email.
Excuse me.
And I tried to clarify my understanding of it. And you haven't let me answer any of your questions without interruption.
I can only see what you have written down in black and white. And that concerns me greatly, because it brings me to the conclusion that you don't understand what regionalisation
is. Do not accept
or you're
that
seeking
conclusion.
to block.
I don't know how you could infer that conclusion.
Okay, I think most people would come to the same conclusion reading that. Anyway, I want to move on. I want to move on then. That strategy and action plan 2021 to 23. In that, a business plan was to be produced last year. And I want to ask you, has that business plan been produced? Does it exist? And I also want to ask you in relation to an integrated financial management system, which we're told you don't have, in spite of it being 17 years since the HSE was existed. So when can we expect to see the business plan for regionalisation, and when can we expect to see an integrated financial management system?
Chair, I'm happy to take the latter or both as well.
Well, could I ask about the business plan first? I asked Mr. Watt about that.
Yeah, so we're...
I could speak to the business plan, Robert, if you like.
Yeah, Mirish might come in. Thanks, Mirish.
Thank you, Deputy, and I can assure the Deputy that the senior management teams of the HSE and of the Department of Health are very committed to the vision for regional health areas set out in the Sláintecare report and to the achievement of comprehensive person-centred integrated care.
Sorry, when will we see the business plan?
Yeah, so the business plan, as you will know, Deputy, was a requirement when the government agreed to the geographies of the 6 regions in 2019. The government asked that business case be presented at the next stage to set out the next steps and the way forward. So notwithstanding the pandemic, there was work progressed within the department to do that business case. It sets out the rationale, the objectives, the demand analysis, and looked at options for the development of regions and regional healthcare areas. And that looked at a number of areas as is versus a HSE local model or a HSE separate model. And while we
when will it be completed?
It's very near complete. It has been considered by the HSE executive, by the HSE board in recent months. We are taking input from the Department of Children and Disability also, conscious that the disability policy will move to them and our shared commitment to integrated care. So the business case is a requirement from us in advance of bringing a memo to government on an implementation plan. So we will have that ready, as Robert says, within the coming weeks. We're finalising the business case now, and that will underpin
when will we see the financial management system?
Yeah, Deputy, and if I can just touch on something, because you did quote myself also in relation to the regions and commitment to regions. And I will take the IFMS as well. Just to say, and I won't go back over the commitment of what we've been driving and what's important for the next phase, but I do want to address the point around our commitment, and you referenced resignations previously, won't go through all of that. I took this job on the basis of driving Sláinte care and driving reform and making it better for the public. I can't go back over 10 years what happened, but I can go back over the past 2 years. And I think we do need a bit of a reality check. If anybody thinks that in the middle of a global and a national pandemic that we were having, when our can I please?
We've heard all this before, Mr. Reid. We've heard all these excuses before.
Do you want me to cut off the section? Because you're way over time and you've asked far too many questions to get in within the 10 minutes.
Sorry, Deputy.
Which we're supposed to get an answer.
Deputy, I was referenced as not committed to the change, so I think it's important I address my own professionalism and character in this one. It's just to demonstrate that I am committed to it, and I was making the point. My priority in the past 2 years, and I make no excuse for it, was protecting the public, protecting our patients and protecting our staff. And if anybody has been involved in any change management in their lives would say that's not the time where you do a massive, probably one of the biggest restructurings that the state has ever gone through. So I make no apologies. The timing was not right to do that. Specifically in relation to IFMS, Deputy, just to make a few points. We've set out, we've funded, I can't talk about 17 years ago, or I can't talk about the past 2.5 years. Thanks to the Department, the Minister, Government, we've secured €82 million to deploy an integrated financial management system. It's quite a complex system. It's going to be rolled out, or the design phase is being worked on throughout last year. We have had issues with the systems integrator that we're in discussions with about termination. We are going to procurement for further systems integration. However, the process is continuously moving on seamlessly. The reality of it is the total, about 80% of the total spend activity across the entire health sector will be encompassed by the year 2025. However, we will start during the end of this year to start load some financial data for the Eastern region and TUSLA that will go live later in in 2023. So it's a very significant programme, massive design of a new integrated financial management system. Yes, you are correct. It's a big miss. It's a big loss that we don't have one, but we have funding for it and the board are overseeing its deployment.
Okay, I need to move on to the next question here, Senator Martin Conway.
Yeah, Cormac, Chairman, and Paul or Mr. Reid, at the outset, I don't think anybody here would, I sincerely, from my own perspective anyway, would question your determination to implement Sláinte care, because ultimately the HSE is an agent of government, and ye do essentially ye implement government policy, but where the real concern is with the Department of Health, and I think, Mr. Watt, that your performance here this morning and what you've said here this morning and your answers to the questions, certainly regarding the email, is very, very concerning, because clearly your understanding of Sláinte care is somewhat at variance with the understanding of Sláinte care that a lot of people here have. And what my worry is, what is the Minister's understanding of Sláinte care? Because if that is your understanding of Sláinte care, what's the Minister's understanding of Sláinte care? And that would worry me greatly, because the regionalisation of the structures is a key component of Sláinte care. And we are 5 years into what was initially envisaged as a 10-year reform programme. Absolutely, we've had a pandemic. So I think any reasonable person would say that you're talking about an extra 2 or 3 years on top of that. But I am greatly alarmed by your answers to the questions, but even more so the combative nature of your answers to the questions as well. So I think that we're going to have to reflect on that because I am very concerned now that you don't understand Sláintecare in the same way that we understand Sláintecare. And while all that's going on, while all this is going on, there are 96 people on trolleys down in the UHL hospital in Limerick at the moment. They are the figures as of today. There has been the bones of 100 million of government money invested into the UL hospital in Limerick. We're talking about 20 million on a unit, a modular unit. Another something like 40 million for a state-of-the-art A&E. You know, I'm just wondering what's gone wrong in Limerick, and maybe, Mr. Reid, you might be able to shed some light on this. Is there any peer review performances compared to other A&Es? How come Limerick A&E constantly is at the top of the scale when it comes to people and trolleys, in spite of tens of millions of euros of government money spent over the last 7 or 8 years to try and alleviate the problem? We're still in a situation that nearly 100 people today are on trolleys. Is there a problem with the management down there? Do you have concerns with the management of UHL that we are in this situation today where 96 people are on trolleys?
Thanks, Senator. Will I come in and then maybe Paul will deal with the second part of the question. First of all, just to reassure the Senator and deputies, and to add to what Paul has said, that I'm absolutely fully committed to this reform agenda and implement of Sláintecare. And the reason I was very happy to be asked to do this job, to take on this role, was to deliver the change, because I believe that the Department of Health, and with our colleagues in the HSE and with Minister Donnelly and the government, that we are and will continue to make significant changes to bring about a system which can deliver better for citizens. That's my motivation, and I don't think anybody should be, along with Paul, anybody should be under any illusions that I'm committed, fully committed to delivering this, and feel that we're making progress and will continue
I suppose it's not necessarily your commitment, Mr. Watt, it's your understanding of Sláintecare.
Yeah,
do you actually, are you on the same page as Sláintecare, for example, as Deputy Shortall is, and other members of this committee is, and indeed government is? The last 2 governments, and I don't know about this government because I'm not sure. You are clearly the Secretary General of the Department, so you speak in tandem with the Minister. So I'm now very concerned that the Minister hasn't the understanding of Sláintecare that the rest of us has.
No, absolutely. The Minister can speak for himself. Senator, I'm not here to speak for the Minister, but the Minister is absolutely committed to Sláintecare and is behind the reforms and is leading the department and leading the team, myself and Paul, our respective teams, to deliver this, and is absolutely fully aligned. Of course, as Mirish has said, there are issues in relation to how we implement RHAs, and those issues are being debated now and discussed, and the government will receive a memo setting out our implementation plan, and then we'll push ahead with that implementation plan. In terms of the combative nature of my answers, Senator, that's a trait. You love or hate it, nothing I can do about it really now. Probably too old to change.
It's not a very endearing trait.
Oh, well, apologies for that, Deputy. You don't like it. That's our Senator. That's can't do anything about that, I'm afraid. If people are going to question my professionalism and my motivation, I'm allowed to defend myself. And if people don't like that, I'm sorry about that.
No, we don't. Yeah.
Good.
Yeah.
Good.
Yeah, Senator, thanks for your question, and I will pass across to just on Limerick specifically, directly to your question. I think we have a very good management team led by the CEO in UHL, and unfortunately does come under for a lot of personal, I'm not saying from yourself, but you know, and understandable, but no, I have very strong confidence in the CEO of UHL and our clinical team that are down there. They do have some real challenges in terms of demographics, and you are correct. There's very significant investment put into it, particularly about 100 extra beds and a new A&E, but there are some really demographic pressures under there, and particularly their capacity capacity in terms of where other hospitals, probably on the East Coast, would have a smaller number of hospitals to step down people into. They don't have that similar capacity in Limerick, and it is a challenge for us, and there's no doubt elective hospitals for the future will give regional capacity for them. But I might just ask my colleague,
just before you do, Paul, just before you do, just in terms of, yes, the elective hospital is an issue, but is there specifics in the next days and weeks that you can do to try and bring these numbers down and to reduce the numbers of people in trolleys? Is there anything specific or specifics that can be done to deal with that? Because everyone knows the problem, but we need immediate solutions as well as medium and long-term solutions.
Yeah, and I'll pass my colleagues who will relay specifically some of the challenges that we have at the minute, which is largely, and at Limerick is a key factor on it, particularly discharge of elderly people, where we have 50% of our nursing homes in outbreaks and we can't discharge to them. But we are utilising private nursing home capacity as well for discharge. But I'll ask my colleagues to give some specifics if I can.
Thanks.
And Arlene, please.
Yeah, thank you, Senator. Liam Woods here. So, yeah, I mean, the reported trolleys this morning, Senator, in Limerick is 35, but I think you're also referring to the fact that there is a surge capacity being used in Limerick, which grows that. And of course, it's a matter of concern to us as it is to the group. The group itself is undertaking a piece of work to look at the key drivers in that, but we know well from Limerick is an extremely busy emergency department in terms of attendances, has remained so right through the pandemic, more really than anywhere else in terms of the volume of attendances. And in the last few weeks has really only been exceeded by the matter in attendances. So it has that challenge at the front door. Things that are happening and that can happen in the short term to assist that. Any delayed transfers of care that can move, and the community has been supporting Dora Doyle, particularly on that. We've been seeking to support that movement so that we would create better flow through the hospital. There are some front door initiatives as well in terms of looking to use more of the Pathfinder, and also use which is a service provided by the ambulance service, and also using Ennis and Nina to the greatest extent possible for step down. And of course, Croom has commenced, has opened its 4 new theatres and is doing really very good work on the access to care side, which we've touched off here.
Do you see any benefit, Liam, in on a temporary basis upgrading the services in Ennis and Nina to try and help with these numbers, even on a short-term temporary basis?
I think Ennis and Nina are doing some very good specific work that would actually be unfortunate to disrupt. And the flow, the key point for us is that patients can flow to Ennis and Nina as needed, and that's happening. And one enabler in that is actually ambulance transport, which we work very closely, obviously, from the group to the National Ambulance Service on. So, but there is already very strong work going on both sides. I don't necessarily see benefit right now, Senator, in extending the reception of emergency patients into Ennis and Nina. But I think the use of them for step down from Dora Doyle remains very important. Remembering that Dora Doyle has actually got one of the shortest lengths of stay in the country for its own inpatients, so it is actually showing signs of relative efficiency. But it's hard to get away from how very busy the front door of Dora Doyle is, and I think there is a capacity challenge. And as you rightly say, there has been significant investment in new capacity, and that has been consumed, and in fact more than consumed, by the rise in attendances over the pandemic and to now. So thank you, Senator.
That's great. Thanks,
definitely, I might just add, if that's okay, just in terms of the work that's going on. I mean, you mentioned short-term and long-term, and obviously enhanced community care is a key enabler for the acute hospital system over time, but it's not an immediate quick fix. But just to say, there are a number of sites, so there's a lot of focus on Limerick, but we have other big Model 4 sites that are very challenged, Cork being one and Galway being the other, and they've been consistently challenged over recent weeks and months, so across our acute and community services, because ultimately the solution to some of the problems that lie in hospitals don't necessarily lie within the hospital to fix. So the solutions are often in the community in terms of hospital avoidance and supported egress, and we have a lot of, as Liam said, a lot of re-enablement.
My time is up,
capacity.
so yeah, thanks very much, colleagues. Thanks.
Thanks, Chairman. Good afternoon to all of our witnesses here. Just first up, I would like to follow on some of the thread of what our previous speaker has been saying about University Hospital Limerick. 96 people on trolleys there today, and on the 26th of January we had it peaking at 111. So records are repeatedly broken in terms of trolley numbers at UHL. It's an incessant problem. It's ongoing and ongoing and ongoing. And I want to begin by asking Mr. Reid and Mr. Watt, the Elective Hospitals Oversight Group, which is looking within Sláinte Care at elective hospitals. I'm wondering who sits on that? Who is that oversight group? Because there was a key recommendation made to government last autumn that there would be 3 new elective hospitals in Ireland at Dublin, Cork and Galway. I cannot for the life of me fathom why the Midwest and principally University Hospital Limerick would have been omitted from that. So could you please detail who is on that committee, that oversight group, and the logic behind that decision, because it is devastating, I can tell you, in the Midwest to have not been in that shortlist.
Thanks, Deputy, for the question. In relation to the elective oversight group, Professor Frank Keane is the chair of the group, and he is leading a group made up then of experts and officials from the Department of Health and the HSE.
Can you name the group, please? I've specifically asked to know who's on it because I need to know this detail today.
I can. If you give me a second, I can get the list of names.
Okay, I'll keep going with my questioning if that's okay, and I would appreciate their names in a moment.
The list, Deputy, hopefully before the meeting out we can
it's just by any metric, by any logic, I cannot understand why the most pressurised group of hospitals in the country would have been omitted from that. This is now progressing as, there's a business case already filed, I believe, for Cork. There's ones pending for Galway and Dublin, and the most pressurised corner of the country being the Midwest. Clare, Limerick and Tipperary, and no suggestion of elective hospital there. I'll come to you with a proposal because this is something I've been taking in the Dáil Chamber as well, and we had some warm and positive responses from the Taoiseach just last week. So there's a brand new road being built along the border of counties Limerick and Clare at the moment, the Limerick Northern Distributor Road. It's opening up tracts of land that heretofore were just grazed by cattle. That road is going to be completed, certainly in its first phase, in August of this year. And the Pittsburgh Medical Centre, the University of Pittsburgh Medical Centre, a non-profit private hospital group, are planning to open a 150-bed private hospital along that route. That's perfectly located near the Limerick Tunnel, accessible to people in Tipperary, and crucially on that border between Clare and Limerick. It is as regionalised, it's as centred within the region as you can possibly get. I think it's essential that Sláinte Care, if you really want to unburden the problems we're having at University Hospital Limerick, that you look at having a public capacity, a public wing within that new hospital to alleviate, to separate out things, I suppose, at UHL. I would ask that become part of your agenda. I don't think this can be a shut door policy on this matter. I do want those names. I want our committee to undertake.
We're not going to get at the meeting anyway. But again,
I'm still talking, Chairman, if you don't mind. What I want is the names of the people, and I want our committee to undertake a body of work actually relating to this, because a corner of Ireland has been left totally out of this report. If I could then move on with my questions to Mr. Watt and Mr. Reid. We've all digested this morning's Irish Independent, and one of the front page stories relates to pay in the higher grades of management in the HSE. So I put it to you, in spite of everything we've discussed here this morning, how can Sláinte Care be delivered when many senior management figures within the HSE are both frustrated and disgruntled? The fact that for 14 years they've been fobbed off by people above them in the management structure in terms of having a legitimate and approved pay awarded to them, all at the same time when, if I can follow what the paper said today, Mr. Watt, in that same time period you had an €81,000 pay hike yourself. So how is it that the people in management levels just below you have had a pay claim approved and it's pending and nothing has been sanctioned? So is that a factor in none of this progressing at the speed we wanted to progress?
Thanks, Deputy, for your questions. And in relation to the electives and the capacity, we'll certainly share with you the detailed work that Professor Keane and his group did and facilitate any engagement that you want to have bilaterally with Professor Keane or at this forum. I'm very happy to set out their plans in relation to the electives, but the rationale for the locations, the proposed structure, certainly very happy to engage whatever format you and the chair and the committee think is appropriate. In relation to the second question, I haven't seen the story in the newspaper, so I can't really comment on it.
I find it hard to believe. If my name was on the front of the national paper, I'd probably pick up the paper and read it first thing in the morning, or you'd certainly get.
Sorry, Deputy. What don't you find hard to believe? Sorry, I missed that.
I just find hard to believe if one's name is in the front of a national paper. I would, relating to pay and conditions, I would assume you'd have read it. But look, if you haven't, you haven't. But I suggest it's worth reading, because it certainly, I think, is a factor in preparing for this meeting. I've had a lot of emails and phone calls from people in various management levels within the HSE, and I have a number of questions I wish to briefly put to you. So you've been repeatedly made aware, Mr. Watt and Mr. Reid, that a group of senior management in the HSE and voluntary hospitals have been unjustly picked out for unfair treatment by the continued withholding of a pay award under Report 42 of the review body on higher remuneration, which dates back to 2007. The award was approved by government, subsequently sanctioned by the Department of Finance, but it was withheld from this group when all others, both in local government and Garda Síochána, across the board, everyone else got this pay grade. And I just want to ask you, how can you stand over this injustice when the very same report specifically said that neither the pay of the HSE Chief Executive or Secretary General merited to be any higher than they were then? So we've seen yourselves get pay hikes of 81,000 when it was said there was no more needed. And
sorry, Deputy.
Chairman, can I just say this happens every week? With the greatest respect, when Deputy Shortall's line of questions, it's always allowed. Okay. But you interrupt me every 2 minutes in my flow of questioning, and I want time added on here, Chairman. No, this is the second interruption I've had. I want time added on, Chairman.
You're not going to get time added on.
Well, then I'll go back to my questions without interruption.
The way it is, you won't. I'll cut you off.
I'll go on without interruptions, because this happens every single week.
It doesn't happen.
It happens every single week, and I'd like that question answered, Mr. Watt, please.
Thank you, Deputy. I'm happy to just familiar with the legacy. It is, Chair, a legacy issue in terms of pay. You've referenced it quite rightly back to 2007. I wasn't here then, just make that statement again. But it is an issue that's been through the various processes, industrial relations processes, pay process between the Department of Health, ourselves, the HSE and DEPR. And it was the subject of various different pay agreements throughout the previous pay agreements over the previous years. So it is a legacy issue. It has gone through, and there are certain processes and procedures in terms of pay, public service pay, which that has been addressed in. And, you know, people feel aggrieved, but there are many different grades that do feel aggrieved, and I have addressed it in relation to my own salary. I wasn't here then. I can't compare my salary.
Okay, can I ask you then, even at this very late stage, Mr. Reid, are you prepared to look at the possibility of impropriety and the possibility that the process used to stymie payment was tainted? And that's been flagged, I think, with both of you by senior management. Are you willing to look at that and why it's been stymied to date, why this hasn't been implemented?
I'm sorry, Deputy, they're your words, and I'm not trying to be disrespectful, but they are your words. They're not mine, and they're not what the...
Words are not. Are you willing to initiate a process of review?
I'm just saying in terms of the references that you made, but those issues are subject to previous discussions and previous pay claims through all previous pay agreements.
Okay. And can I ask both yourself and Mr. Watt, do you accept that the salary increases granted to the posts that you both occupy were in breach of the same FMP legislation used to deny payment to other management in Report 42?
Sorry, Deputy. Look, I can't comment on what the role. I can only comment on my own role right now, and pay associated with my own role, not related to what it might have been 17 years ago or 2007. And I've answered very clearly, and I've tried to be very clear about the process for my own pay. What concerns me, you see,
what concerns me isn't so much the pay. I'm not here to ask about pay, but what really concerns me as a politician and as someone who represents taxpayers in my constituency, this is, I believe, we often ask, what are the stumbling blocks in the HSE in terms of delivering service? One of the major stumbling blocks is we have a huge cohort of very disgruntled senior staff who have been waiting far too long for an award made to them, approved by government, some in the organisation are getting pay increases, others are not, and this, I think, amounts to dysfunction within management, because within any walk of life, you can be sure that kind of division permeates into all levels, and it ensures that the organisation isn't going the direction it needs to be going in. I think you need to give some hope that a lot of them are following here today and they're listening, and both you and Mr. Watt are the helmsman of the HSE, that this is going to be actioned on, that there will be some internal review arising from today, because it is a factor in where the HSE, I think, is coming up short at the moment.
Chair, I've answered the question. It might be to the deputy satisfaction, but it has been through various.
I have to raise in the door because it is a major factor. You both very well know what this is about here today, and I think it needs a high degree of addressing. And Chairman, I'm just going to conclude by saying I think when a TD or Senator is in possession of time, the questioning is reasonable. It's very much focused on the agenda here today. I think we should be allowed to proceed without interruption. I think we have a body of time to exchange, and it has just eaten up some of my 10 minutes again today.
Okay, we'll take it up with the chair after the meeting, and we can discuss it then. Sean Coyne is next. Colin Burke, sorry. Colin.
Sorry, thank you very much, Chair, and thank you to both the department and the HSE. And I suppose it has been a very challenging 2 years, and just to thank everyone involved in dealing with the whole COVID issue and the challenges that have been posed by that. And I suppose I want to move on to the here and now and where we go from in relation to healthcare in Ireland over the next 5 to 10 years. And one of the issues that's going to occur, and is there already, is difficulties about recruiting. And I'm just a bit concerned about the disparities that has occurred in relation to recruitment. For instance, since December 2014, the numbers in working HSE has gone from 103,000 up to 131,000. That's a 27% increase. In relation to senior management, it's gone up from 1,185 to 2,104 to 2,154, which is an 81% increase. But then when you go down to home help, 14 was 3,703, and in October 2021 it was 2,352. So that was a decrease. And I'm just wondering in relation to, and you referred earlier, the Secretary General referred earlier to the demographic change that's occurring, and in particular by 2028, the demands in relation to both our healthcare sector and in relation to the whole area of trying to home care and all that area, there's going to be a dramatic increase. I think we're going to go from about 740,000 people over 65 up to over 1 million. How do you propose addressing where there are shortfalls in recruitment and where there's a shortfall in getting staff? Is there a plan in place, and what does that plan envisage?
Thanks, Deputy. Maybe I'll say something, and then Paul and his team can come in afterwards. I think the numbers you did indicate show a very significant increase in the numbers employed right across the different areas of the healthcare system. As you say, almost 30% increase in the last number of years. As you mentioned, the last 2 years gone from 120,000 to 132,000, and there's plans for further increases again this year, between 5,500 and 10,000. And as Paul mentioned earlier, there are recruitment challenges, and I think there's two aspects of this from our perspective, I think. And Paul and his team can come in with some of the detail. First of all, is for us to become more effective at recruiting internationally, and we've made changes, for example, in terms of the registration of nurses to double the number of nurses registered from overseas this year. And secondly, then it's to provide more training opportunities for our young people and more training opportunities for people within the health system to progress. But this is a societal issue that, as the demographic effects kick in, healthcare is going to become bigger. And we need to train more of our people to work in the sector, and we need to be attractive to bring people in from overseas. And there is a workforce plan which we have for this year, and that's evolving then into a multi-annual plan to try address these issues. And across there are many different areas, Deputy, as you're aware, and Paul has touched on some of them, and we're pushing ahead with all of those areas. There's more acute problems of recruitment in some than others. but everybody is focused on trying to do as much as we can to get people in.
You mentioned about retaining people. One of the issues in relation to junior doctors is that if you come in from outside of the EEA, outside of the European Union and the EEA, you will not get a stamp 4 until you're here for at least 5 years. There's a proposal that would be reduced down to 2 years. My understanding is it's now stuck in a logjam between the Department of Justice and your department, and I think the Department of Foreign Affairs. I'm just wondering, when will that logjam, because there's a lot of junior doctors who are here who don't have a stamp 4. They cannot get any training facility, any training here. Therefore, they don't see any point in staying in Ireland. When will that logjam be resolved?
Well, absolutely. I'll come back to you on the time frame, Deputy. I don't have to hand exactly because I am aware it has been worked through, but it's something that was identified to the Minister last year as something which needed to be fixed and reformed to provide opportunities for doctors to access that training. And that's something that the Minister has progressed with the Minister for Justice, but I'll check with you exactly where we are. I'm not sure in the exact time frame or what's causing the blockage, but certainly the policy, I think, is a very progressive policy which will help opportunities for many doctors to continue to stay in Ireland and progress their training and have hopefully productive careers here in our health system.
The reason I'm raising this issue as well in relation to young people, normally, traditionally, many young qualified nurses, doctors tend to go abroad after qualifying or maybe after doing a year or 2 here. That hasn't happened over the last 3 years. So we're now going to have, whether we like it or not, we're now going to have quite a substantial number of young trained people leaving this country. And the question is the HSE and the department planning for I've spoken to quite a number of young people over the last number of weeks now who are planning of moving out, because they hadn't had the opportunity over the last 3 to 4 years of travelling. They now want to do it. Therefore, there is going to be a shortfall. And how is the HSE planning for that? And how is the department planning for that?
But just before Paul comes in again, Deputy, obviously there are people who are going to leave the country for a whole variety of reasons, which are unrelated to the health system, and obviously that could raise a challenge for us. But I'll pass over to Paul.
Thanks, Chair. Thanks, Deputy. Just a few questions on the wider process that you just asked on recruitment and retention. Just first of all, we have put a very new model in place over the past 2 years, which devolves a very significant level of recruitment to services for them to do it directly. Secondly, we have worked with the Public Appointment Service to accelerate the process, particularly in relation to consultants and senior professional medics, and that has helped significantly. We've also thirdly put in place a new recruitment model ourselves, which is with a third-party provider to operate a scale well above what we would be able to do, because, as I mentioned earlier on, 35,000 people over 2 years is very significant. I'll ask my colleague in a minute just to comment on the home help issue, which is a real challenge, which you have highlighted. I would just make 2 other final comments. One on people leaving. And I agree with Robert, like, young people will leave for various reasons, and our own families, I'm sure many people you know have left, and some come back, some haven't, and that's a function of, factors people make. But specifically for us, and I mentioned the figure earlier on, it's very significant, 9,500 people to stand still that we have to recruit every year. So when we talk about 12,500 people over 2 years, there's a further 19,000 people that we've had to recruit just to stand still. So there is a lot of churn. The final comment I would make, and it's more a plea, Deputy, not to yourself, but just in general, there can be some awful generalisations made about the health service. And I've listened to some commentary over the weekend, not by politicians, but, it's an awful place to work. It's a basket. Who would go there? It's actually a really good place to work, full of highly committed professionals. And some of this general tired statements are made at times do really hurt us and hurt our staff in terms of retention. So this is a good place to work. And similarly, I'd say at senior levels, there's an increasing personalisation of senior roles. And I'm not talking about my own role or anybody's, but it's this increasing personalisation of public service roles that doesn't do good to get the right people into the public service. And I just make a general comment on that, because that is about recruitment and retention of the best people.
Can I just move on to an issue in relation to the whole capacity in Cork and in the Cork area region? For instance, last night I received a phone call at 10 o'clock last night where a member of a family contacted me where their mother was in accident emergency in CUH, since Sunday night. So 50 hours later, she's 92 years of age. She was still in an accident emergency at 10 o'clock last night. Therefore, there is a huge problem with capacity in Cork. And the HSE, in fairness, in the South-Southwest region, presented a plan back 3 years ago. We still, 3 years on, haven't even identified a site. And we raised it with the Minister last night. Now, my understanding is that there is a report with the department about that elective hospital. I need to know what kind of time frame we are before it goes out of the Department of Health and onto the Department of Public Expenditure, because that's what the Minister said to us last night. Can we fast track that proposal, number one? Number two, can we fast track the entire project? For instance, when I was Mayor in Cork back in 2003, 2004, we fast tracked the project in relation to building an extension to the City Hall, where we invited in design, build, finance, and paid back over 25 years. And we got it built in a very short time frame, a huge extension onto City Hall in Cork. Can we do that with elective hospitals rather than going through a process that will take 4 to 5 years from the time we identify the site to actually getting physically built?
Thanks, Deputy. Just in relation to the latter point, Paul, may wish to come in on other points you made. So absolutely, it's our intention to fast track and build this as quickly as possible. So a business case is now with us that goes through the assurance process with Deeper. And rather than doing things sequentially, which has been the norm, we are now going to do a lot of this assurance in parallel to get through it as quickly as possible so we can get final approval for government and we can start the detailed design and start the procurement process. So we are doing everything we can, Deputy, to accelerate this. In terms of when we get to the actual procurement and construction stage, I've heard your suggestion. I don't know the details of that, but absolutely we are open to working with Deeper and with Paul's team in terms of any options to accelerate this. Like, there's a challenge always in Ireland about building things. It takes a long time. It takes a long time for reasons that we're all aware of. Many of those reasons are legitimate, but we need to do everything we can to accelerate it. And we can't have a situation where we're having this debate in a year's time where we haven't started the detailed work. We need to start the work and we need to build it as quickly as possible because it's urgently needed.
Even identifying the site, we, like the HSC have a site in Sarsfields Court in Dunmire. It's 100 acres. So you can actually start, you can build block by block there into the future. And it's about long-term planning where you're not in 3 or 5 or 10 years time looking for additional space. 100 acres of land which is owned by the HSE and which is underutilised. Let's at least identify the site so we can get on with the job of getting this and then dealing with the capacity issue in Cork.
I absolutely agree with you, and it isn't a question of land or sites. It's a question of ultimately how quickly we can get this through the process and start building it. That'll be the bottleneck. But I absolutely agree with you, and it's a priority for the minister. And I know he's met with TDs and senators and councillors from the area, and he's fully committed to it. So hopefully the next week or two we'll have some news on where we are with progressing this project.
And in relation to getting it to the building stage, I mean, can we look at fast tracking that?
We are. We're the various assurance processes that we have to go through set out by Deeper, and we're going to fast track that and deal with them in parallel rather than sequentially. So we're doing everything we possibly can, Deputy, to get to a stage where the government can finally sign off and we can move to detailed design and procurement. So hopefully mid-year. I don't know the time frame, but before mid-year, we hope to get to the next stage and going out for a tender to start this process.
And Deputy, apologies, I was going to come in just answer the wider. We have put some teams in place into Cork University Hospital, working very closely with local management, looking at flow through to the hospital, looking at allocations, bed allocations, and best use of capacity within the Southwest Hospital Group. And indeed, as I just mentioned earlier on, my colleagues are going there tomorrow. I might just ask them if they want to make generally just any comments in Cork at the minute.
Yeah, so I think definitely the reality is Cork has been under huge pressure. We've seen it throughout the last number of months in terms of just the level of attendance and their capacity. So they have been challenged in terms of the level of demand, but equally their capacity to discharge from the hospital to community services and home. We've had people down there, as Paul said, working with the site, looking at integrated solutions between the hospital and community services, looking at how they use the capacity they have and looking at how they can introduce models of care that could have an impact. As I've said earlier, really the level of demand that we're seeing at some sites is quite extraordinary, and they really are experiencing a huge surge over recent weeks. So notwithstanding that, we're down there tomorrow, Friday, really, in terms of working with the services to make sure that we are doing everything we can nationally to support both the community element in terms of hospital avoidance, the discharge element, and then the use of all available capacity across the health system.
But just in relation to getting work done in the HSE, for instance, last year in 2021, funding was made available for the building of 2 new theatres. Everyone expected that they would be finished by November of 2021. It turns out that a contract for the building wasn't signed until November 2021, and we're now talking about July, August of this year before those 2 new theatres are built. You know, can we not deal with that type of delay that's occurring in relation to the healthcare sector? Why did it take 10 months to get from the time money is allocated to actually getting a contract signed? The tenders were already in February, yet it was November before contracts were signed.
I'm not sure the detail of that. I don't know.
Deputy Liam Woods here. I'll come back with details on that. I think the point you're making is, can we accelerate the process? But on the specifics of the individual case, I'll come back to you.
Okay, but it's that kind of delay where we're losing. Okay, but we're losing valuable time, and then we have problems where we have consultants at the moment where they're looking to get a half day a week in operating space because they can't get access to operating theatres, and that needs to be looked at. And that was done by the gynae services in Cork, where it was 4,500 on the list. They got time in the Mater private. The consultants went down there and they actually cleared over 3,000 off the list in a very short time frame.
Right, I'm moving on. Sorry, Sean Kynes next.
Thank you, Chair. I'd like to welcome Mr. Reid and Mr. Watt and the teams from the HSE and the Department of Health to the committee this morning. Just a couple of questions initially. Obviously, GPs play a pivotal role in terms of delivery of sláinte care. They were before the committee a number of weeks ago, and one of the issues that they had was in relation to the need for an establishment grant or tax relief to establish practices. Is this something that you believe and that you will be lobbying for within your budget negotiations, particularly Mr. Watt in your previous role as well? And just the second question, the notification of pension entitlements to staff. I raised this in a commencement debate in the Shannon last week, I think it was, taking over a year before staff who are on the verge of retiring or may need to retire early due to burnout before they're actually notified of their pension entitlements, and indeed taking a number of months before the receipt of a first pension check is being received by hard-working frontline staff.
Thanks, Senator Klein, for that. I find it very unlikely that I will be lobbying the Department of Finance about tax reliefs for any group during my time as Secretary General of the Department of Health. I think that's a very low probability that will happen. But I haven't seen the proposal, but I'll have a look at the proposal. I think the way to remunerate GPs is to provide their remuneration through the health vote, which we do and have been doing significantly over the last number of years. Very significant resources available to the GP sector. In relation to the pensions, I think is that a HSE issue? I think. I'm not sure, Senator.
Just on that first point, if a shortage of GPs is an issue in delivery of sláinte care, why wouldn't you be taking on board the issues that they raise?
So I think the shortage. Look, I'll have a look at the proposal, Senator. I haven't seen the proposal. Okay. Like I think the shortage is about us training more GPs, which the numbers have increased. I think we're up now to 250 a year we're training, and there's a proposal from the general practitioners to increase that to 350. So we are training more GPs. I know there are issues in particular locations and there's various proposals in about how we can make it more attractive. I think Paul alluded to this earlier, that in particular parts of the country it's harder to get GPs, and when we have GPs retiring and moving on, to get the next generation in to replace them. But certainly, look, Senator, we'll have a look at the proposal.
Okay.
But I think as a general principle, we don't like lobbying the people who pay the bills, getting them to reduce the tax base is not necessarily what we do in the Department of Health, but I'll certainly look at the proposal.
Okay. Mr. Reid.
And very briefly, Senator, just on the GP one first, just to add to what Robert said there, it is a big issue for us. We're working very closely with the ICGP on this in terms of how we bring through further trainees on the ICGP training programme. We were about 10 years ago about 135 GPs a year coming through the programme. It's at about 235 at the minute. We do want to get that up to 350 by 2028, so over the next few years, and we're working very closely. What we have done is reassigned the training roles and responsibilities and people across to the ICGP where it fits better in terms of that programme and training. And we're also looking at some non-trainee positions in doctors and hospitals that can be assigned as trainee positions into GP to try to give some further relief into it. So it is an issue that we're very conscious of and working closely with the ICGP on. On the second point, Deputy, what I'll have to committee is come back with a brief note. I'm not totally familiar with the notification of pension entitlements and delays specifically in them. I have heard some exceptions, but I'll get a brief note back to yourself.
There was a commencement debate last week taken by Minister Anne Rabbitte, so she did undertake to bring this back to the department. It is an issue certainly in the Sylhet area, but I understand across the country as well. Can I ask, in relation to the delays in the lodging of planning application for the Galway Emergency Department and the whole saga regarding elective and acute beds in Merlin Park, there is still a huge level of confusion in Galway, and it is best exemplified in basically where I've been advocating in relation to childhood orthopaedic theatre and services in Galway. Again, they need a fit-for-purpose modern facility, and yet they don't know whether that should be at the University Hospital Galway site or in Merlin Park site in conjunction with elective hospitals. But the elective hospital will be a day hospital, won't have overnight beds or acute beds, certainly not in the short term. So there is still a huge level of confusion in Galway in relation to progress. So can I ask, in relation to the ED planning application, when is that likely to be lodged at this stage? It's long overdue, and it's something that I know there's a temporary ED being built at the moment to facilitate the development of a new ED. Some people actually think in Galway that is the new ED. It's not. It's a temporary facility. So can I ask, when is the planning permission likely to be lodged?
I might just ask my colleague Liam Woods again to come in and comment. Appreciate the frustrations in Galway overall. Liam, do you want it?
Thank you, Paul. Thanks. I've just saw it. Actually, I don't have that information in front of me, but I'll come back to you with it shortly in terms of.
Sorry, Liam. I mean, there's only a number of us on the committee. I mean, I'm here from Galway. There's a number of deputies and senators from Limerick. Of course, I'm going to raise an issue in Galway that I've raised before, and like these things frustrate me. And the same when the minister appeared here. There's no information. I'll have to come back to you. You should have that information. You should have that information in preparation for a committee meeting. And it's frustrating, and I don't normally get annoyed, but like, I mean, that's the basics when you know who's on the committee.
Deputy, can I just, sorry, go ahead.
So, Deputy, I'm very happy to answer the question, and I will answer it to you shortly. I was just going to go on and say I understand the work is done to do that. I don't want to mislead by giving a wrong answer, so I will come back to you with the answer.
Senator, I just want to assure you the preparation that we and our teams put in place for coming across the committee is extremely significant. We will be up against about 5 committees over the next 5 or 6 weeks, over the next 3 weeks or so. So we put a lot of time and focus in it, so we may not be able to answer all the questions on our feet. And the scope of what we were told or advised today was the regions and governance. So, appreciate we don't have all the answers to every specific one. I think we've captured most. And we will come back.
I find it hard to believe that you, with the full team that are there, that you don't have information on projects like this that are vital. I mean, we can talk about delivery of sláinte care, that's hugely important, but all projects are vital in relation to delivery of services. So you have no information in relation to acute beds in Galway, in relation to the whole saga of a €3 to €4 billion hospital in Merlin Park. No light can be shed on any of those things at this meeting. I mean, I don't get an opportunity often to address the head of the department or the HSE.
The elective hospitals, I think Robert may have covered in, or Marish might want to just touch on in terms of the process, particularly in relation to the business case progressing for the three of them. I'm not sure, Marish, if you want to make further comments in relation to Galway.
I don't have further comment to offer, Paul, on that.
Sorry, just in relation to the Galway elective. So we do have a site identified, and again, the business plan has been progressed, and we hope Senator to progress this. The timeline, I think, is similar in relation to Cork. So we're working away on this, getting through the assurance process, and we hope to be able to say something more definitive the next few weeks in relation to both the Galway project and the Cork project.
In relation to the delivery of acute beds in Galway, again, it goes back to the whole division in Galway at the moment, as far as I can see, within the Celta Hospital group over where things should progress, whether it should be Merlin Park or ED. And the people of Galway are caught in that debate. There was no acute beds provided under the winter plan, which was highlighted, which was unbelievable, considering we had the highest level of people on trolleys for an 8-week period. Where are there plans for acute beds for Galway in the short term or the medium term? I know there was a couple of lines added on to the memo and the press release in relation to the elective hospital. And as far as I'm concerned, that was nothing more than a political fig leaf in relation to future plans for acute beds. Are there any short to medium term plans for acute beds in Galway, either at UHG or at Merlin Park?
Just, I might come in, definitely in terms of just some of the immediate, I suppose, actions that have taken place. We have just, I believe, in the last week or so, opened 26 beds in Merlin that are step-down beds to support the pressures in GUH. And that is just, I think, in the last week, those beds have been opening. So in terms of an immediate pressure relief, and you're absolutely right, the pressure in Galway has been unbelievably high for many weeks and months throughout the winter period. When we work with Galway any year in terms of their winter planning, as we did this year, they're very challenged in identifying any location where they could put extra beds. So, for example, a modular build or anything else. And we've been working very closely with sales in that regard. Galway has been top of our priority list for, I think, now the last 3 winters. And certainly from their perspective, the lack of other capacity around them, unlike some other parts of the country where there are more hospitals or more different types of facilities around them. So they are very challenged, and equally they haven't had as much capacity available to them in the private hospitals compared to some other parts of the country. So they really are a bottleneck. We do see that. We've been working with them in terms of looking at their existing site to see if there's capacity that could be built on the site of GUH, but that would involve them moving other capacity around. So it's really not a straightforward site at all in GUH, as you're probably aware. And I think for us, the solution has to lie in Merlin, where there is obviously space, but the immediate step that has been taken in the past week has been the creation of those additional step-down beds.
Thank you for that, Ms. O'Connor. Again, this goes back to the whole debate. They cannot find a site because they don't know should they look for it in UHG or in Merlin Park. And I've said this before umpteen times, the births, deaths and marriages clinic is right beside the hospital. There's no need for that to be there. That can be delivered elsewhere. That is a prime site for delivery of acute beds for Galway or indeed other services. And that is a matter for the Department of the HSE to investigate and sort out. That is right beside the existing site at UHG.
Okay, I need to move on. We have Senator Annie Hoey next.
Thank you, Madam Chair. Hope you can hear me all right.
Yeah, go ahead.
So I have 2 questions or 2 topics to focus on, so it won't be too lengthy. Last week in discussion we had at the Mental Health Committee, a member of the Irish Association of Hospital Consultants made a really interesting comment that I think is pertinent to the discussion we're having here today. And he's saying that we can publish as many plans or reports upon which we can all ideologically agree, but these reports need to come with implementation strategies, and we need to move to a place where we have a roadmap for implementation as a companion for such plans. So I want to ask if you could give us a steer on like the implementation, I suppose, of reporting on sláinte care. So, you know, for example, for the forestry sector, there's a dashboard that everyone has access to, and you can see what targets have been met, how many things have been chopped down, how many things have been planted, and how it aligns with the targets that have been set out. And I think, you know, it's particularly good for public accountability. It's particularly good for those public reps to be able to see what's happening. So I'm just wondering, is there something like that that can be done? Because we're, you know, the public want to know what's happening with sláinte care. We want to know, and we get you in obviously to be able to ask questions. But that very clear accountability, something, you know, like that dashboard piece of work. I don't know if there's any conversation around that, if there's plans for something like that. But I certainly think it would be, you know, might save on a little bit of the argy-bargy that sometimes happens, and it creates a very clear, transparent accountability for sláinte care, which I think the members of the public would like. And then the second question, I'll just ask the question, and then I'm happy for both of them to be answered. And it's around, you know, reflecting on the kind of the rates of core pay that we have at the moment. And my party colleague, Deputy Alan Kelly, in the chamber yesterday said, he listed off a whole number of things. You know, 700 consultant posts are vacant. And we know that from Simon Carswell in the Irish Times about the shortage of GPs across the country, and 1 in 5 GPs are expected to retire by the end of the decade, and we need 2,000 more. And in 13 GP areas, medical card holders have been out permanent doctor for a year, and, you know, so on, so forth. You know, I need not go into the depth of it. And it's a genuine question. It's not designed to trip you up. Do you think with the rates of core pay as they are right now, that we're ever actually going to be in a position to hire enough staff to implement sláinte care in its fullest? You know, we're here about the rates of the core rates of pay and how it's not enough to attract people into it. So if we continue with the rates of pay as they are we actually genuinely ever going to be able to get to where sláinte care needs to be, or does there have to be a real genuine conversation about how we're going to get that to happen with the rates of pay as they currently are? And those are the two questions: the implementation, or the dashboard, if you will, and then the rates of pay and whether we can reach sláinte care goals.
Thanks, Senator. Maybe I'll go first, and then maybe Paul or his team may wish to come in afterwards. So we have produced a report along the lines that you suggest yesterday, the sláinte care implementation. I know it wasn't produced perhaps sufficiently in time for this committee, for yourself and colleagues to go through, but it does set out, in effect, what you're suggesting. There are 228 deliverables, which we set out, and 200 of those deliverables have been progressed on track or with minor challenge, and others, of course, that where there's significant challenge, 28 with significant challenge. So we have set out, Senator, that dashboard, if you like, that traffic light type system, and we'd certainly welcome any comments about how it can be improved and how that reporting improves. And that's sort of a key part of our accountability. And this sets out what we've done in relation to 2021. It's a progress report and sets out where we're making progress and where there's challenge and where there's significant challenge. And we've touched upon some of that this morning. I don't think that no matter what we produce is always going to be argy-bargy, Senator. Argy-bargy shouldn't necessarily be seen as a bad thing, okay? Debate is good, challenge is good, but I think no matter what we prepare, there's always going to be contested space and health and other areas of public policy given its importance. But we certainly welcome any suggestions this committee has in terms of what reporting, improved reporting you may wish to see, which would help you to do your role to call us to account. In relation to recruiting, as we've touched upon, significant recruitment has taken place. There's challenges around that, and there's a whole variety of things that we're doing and trying to address those challenges. I think there's a wider societal piece about making the health system attractive for people, and it's about pay, it's about working conditions, it's about the overall sense of the discussion around health. And I think Paul touched upon this earlier. Working in health, it's a fantastic career, fantastic opportunity, and it's much more positive than negative. Of course, there are negatives, and unfortunately in our public debate now, the negatives drown out most of the positives. And I think there's a challenge for Paul and I and our teams and others to communicate better, perhaps, the positives of health in terms of what's been done, the achievement, and the enormous pride that people have in their work, because that's what you get all the time, how people are enormously proud of working
in the HSC, working in other parts of the health system, working in the Department of Health, and how they feel they're making a contribution. But I don't think it's just about pay, it's about a whole variety of issues, structural issues, and making employment attractive as possible for people.
Yeah. Senator, just to add a few brief comments to what Robert said, and I just said some figures earlier on in terms of recruitment overall. I mean, these are 2 years which are unprecedented to have recruited 35,000 staff and 12,500 net in the last 2 years. But what's more important to me is that the mix of those have been a much better mix than might have happened in the past. So 3,300 nursing and midwives, of which over 2,150 of them have been staff nurses and midwives, healthcare assistants, almost 2,000 of them, and patient and client care, including healthcare assistants, over 2,300. The challenges we do have, and you've touched on some of them, certainly in terms of consultants, it's been 358 net increase in consultants over the past couple of years, but that is a massive challenge for us across all the specialties, and particularly, as I mentioned earlier on, in some geographies where we're finding it particularly difficult. In South Kerry was a clear example of that, indeed Donegal can be as well. So severe challenges in some areas and regions in particular. Where highly qualified professional consultants like to be in the big urban centres and like to be in the big urban functions. The one other point I would just add to what Robert said is, and I do, it's something I passionately believe on. I talk to a lot of our staff quite regularly. We would have been able to get out and about much more, but we have webinars and we talk. And I do, passionately believe our teams like working in the health service. Yes, when things go wrong, it's not good, and none of us can stand over things that have happened, whether it's South Kerry or other instances that happen where wrong harms. But overall, in terms of the Irish Health Service, we do provide, by equivalent with other health services, a good service in terms of people's longevity, people's life cycles, cancer treatment, cardio treatment. It doesn't always get reported on. And I am a Robert to the extent, and it's a role for me as leader, it's certainly a role for me and my teams, but it's a wider public role in terms of how we draw out many of the cliches about the HSE and the health system. It does hurt the system, and it doesn't make it easier for us. And I'm not saying not to challenge a criticism or, have a go of us where people need. But the general commentary don't always reflect the reality of what our teams are committed to in the health service, and I'm committed to help them as well. But just specifically in relation to GPs, I won't go through it again, but it is a challenge, and I went through some of the figures earlier on where we're trying to scale up with the ICGP. Everybody's committed to this one. Thanks, Senator.
Thanks for that. And I just think it's one of those things that we just have to get to grip with. If there's not enough money coming from government, to employ people to achieve this goal that everyone is. And I take the comment you have around it's wider than just pay. Do you know what I mean? Like, that's something then we as political representatives have to take very seriously. And obviously, as someone who's a workers' rights person, a fair day's pay for a fair day's work is something that's really important. I just think maybe we're just not getting to grips with that. And I would say, just in response, to have a look at the forestry dashboard. It's a hard accountability system, but it's very accessible to the public. And the reality is that members of the public, I'll read a report. Some members of the public will read a report, but not everyone's going to read a report. And I think that dashboard system is, as I said, it's hard accountability. It has numbers, it has figures. You can't, and I think something like that would be really useful for members of the public to see where Sláinte Care is going, because we talk a lot about it and give a lot of time to it. But Chair, that's all my questions. Thanks very much.
Can I just say, Senator, definitely we'll look at that suggestion and see can we improve on that.
Grant, just before I bring in the other members, just the Sláinte Programme Board, I think you've met once. How often do you propose to actually meet? I suppose the big question is, what are you going to do differently in relation to that? And the elective hospitals mentioned in Mr. Watt's opening statement, what's the earliest date that you hope to see those opening? I would have liked to ask about waiting lists and the action plan. You're talking about 5% reduction, but based on that, it'd be 40,000 patients a year, it'd take 18 years. But again, maybe in a written reply, could you give us some sort of sense of how you're going to reduce those waiting lists and a time scale, if you could?
Thanks, Chair. In relation to the oversight, the new board, we've met twice since December, and we've been meeting every second month or more often if needed. But of course, as you mentioned earlier, the teams meet every week on the different projects, and in relation to some of the projects, I guess several times a week. So there's a lot of activity happening below the teams, and then issues are elevated to Paul and I each week, but formally then at the board structure. And we'll see, Deputy, how that evolves over time. We're not wedded to this particular format. We'll see if it works. We continue. If we think we can improve it, we make those tweaks. In relation to the electives, I don't have a timeline for when they're going to be delivered, when they're going to be opened. Like we're now 2022, so hopefully we'll get to the stage where we're going out for detailed design and procurement mid-year. It normally takes 2 years, 3 years after that to get the procurement in and to build. These facilities are quite large, not quite as large as some of the hospitals we have, but they're quite large in terms of their footprint. But I'll come back to you, Chair, if I may, just with a more concrete timeline on that. I don't have that to hand, but I'll come back to you. But it will be several years. In relation to waiting lists, like Paul and I touched on this very briefly today. Obviously, we're constrained in providing all the detail because it's not finalised yet and it hasn't gone to government. It wouldn't be appropriate for Paul or I to give all the details, Chair, before the Taoiseach and ministers have had an opportunity to consider it, because it's a very important government decision for them, and they will have an opportunity next week, hopefully, or this week, to consider it, then debate it formally next week when they meet, and after that. But it will, the targets do involve significant reductions in waiting lists this year, the end of this year compared to where we are now, a very long level of activity, but it will still involve large numbers of people waiting at the end of the year. Hopefully the number of long waiters will also be reduced, and that's a key aspect of the plan as well.
Okay.
But this challenge of waiting list will take a number of years to address. It's not going to be addressed in 1 year in order for us to improve our performance, to reduce the numbers of people waiting, and it's really to get to the target that people don't have to wait more than 12 weeks, 3 months in the main. That's what we need to get to. There's always going to be waiting, but to reduce the waiting time to a reasonable, that's a challenge. But
okay,
next week, Chair, that'll be published, I hope. It's up to the government, of course, and the next opportunity, Paul and I can discuss that in detail with the committee and discuss the methodology and the targets and what we're hoping to achieve.
Okay, just a question each from Deputy Cullinan and Deputy Sharda.
Thank you, Mr. Watt. We had a discussion earlier on the email that I walked you through, and Deputy Shortall made reference to your wording as well, where you say over time you will seek to expand the remit of hospital groups to include community services. It goes on to say that there are complexities in this as the geographies of the CHOs and HGs do not align, which of course they don't. They will only align once we set up new structures geographically, which have already been agreed. So can I ask, is it the case then that your first approach here, it seems from my reading of this, maybe I'm wrong, is that you want to expand the remit of hospital groups to include community services, probably align or amalgamate leadership teams across CHOs and hospital groups, and what's your time frame for that? And second of all, why is that being done within the current geographical alignment, as opposed to sticking with what Sláintecare had agreed, which is the 6 regional health areas? And then what's the timeframes for this? Because I have concerns, I've expressed them already. There are concerns also that were expressed by people who resigned from Sláintecare in relation to whether or not this would be satisfactory. But what's the timeframe that you envisage for their new regional structures to be in place in full?
Robert, I can speak to that if you want. Definitely, thanks. Just in terms of the direction that we're working under, the HSE senior management team, the Department of Health senior management team, and the senior management team of the Department of Children are working under clear direction from Robert and Paul to implement the regional health areas consistent with the Sláintecare vision. I think the commentary on the email is overplayed and isn't consistent with the work programme underway. The frequency of meetings was mentioned, and there's meetings every fortnight at least on the implementation of RHAs. The implementation team consistent with Paul and Robert's overall responsibility for the implementation of Sláintecare, connects their senior management teams on a very deep basis to implement the programme. Our high-level timeline, Deputy, is to have a detailed implementation plan completed at the end of this year, to work through 2023 to phase in implementation, and all going well to introduce the regional health areas from 2024 onwards. Recognising the importance of engagement with this committee, with the public, and particularly with staff across the health and social care system, in the preparation of a detailed implementation plan, our intention would be by the autumn, by September or so, to have a comprehensive plan for deep engagement with yourselves and with all interested parties in it. There's a number of work programmes, and I think Robert and Paul have spoken to the scale of the reform programme. And it's not that it's not a caution about the ambition of it, but it's a recognition of just how fundamental it is and how important it is to maintain service delivery through the period of implementation. So we have work streams that we're standing up now on governance, around corporate and clinical, workforce planning, which is featured here in this discussion, the opportunity to totally reform and bring great visibility to the allocation of finances on a population basis, capital infrastructure and engagement. So that's the high level time frame, Deputy, and I hope assurance about the senior level engagement on this.
Thank you. Roisin, last question, quick question.
Sorry, what time are we finishing?
Finishing now?
It's not a 3-hour meeting now?
No.
Oh. Okay, that's my understanding. Mr. Watt, I just want to ask you about a couple of things then. So, first of all, in relation to the status of the individual health identifier and electronic health record project, the business case for those was in 2016. Where is that at the moment? When are we going to see a workforce plan? And the last part of that then is in relation to change management and reform, and I appreciate that yourself and Mr. Reid have extensive experience of that in other organisations, but health sector change management and reform is quite a different kettle of fish. And I'm just wondering, have you brought in any expertise in relation to this area, and specifically, have you spoken with the expert team from the Trinity Centre for Health Policy and Management, who provided the very strong policy base for the Sláintecare programme? Sorry, that's from Mr. Watt.
Thanks, Deputy. In relation to change management, we have brought in some people within the Department of Health, and there'll be further changes in the period ahead, helping us with this change management. They augment the excellent team that we have in at the moment. So that's something that is happening. In relation to the team in Trinity, yes, I have engaged with them, and I've met with them, and we've chatted about the various implementation challenges and what we're trying to do. The health identifier, just let me check exactly on the time frame for this. Just give me a second. So let me come back to you with Deputy a time frame in relation to the health identifier. I don't have the exact details at hand, but we'll come back to you on that.
When will we see
what was the
second question?
Sorry, the middle question. Sorry, apologies, I missed that.
Sorry, the workforce plan. When are we likely to see that?
So obviously we have a detailed workforce plan for this year, which Paul and I have spoken about a good bit this morning, and that sets out our plans in relation to the numbers we hope to recruit and across the different areas, the different specialities, and we have a further piece of work which has been done to look at a more structural is available in relation to that. Just bear with me 1 second.
So sorry, are you saying that the one that you have is just for the current year?
Where's the?
I'm happy to comment just on a couple of points, Robert.
Thanks, Paul. Yeah, I'll just check with that.
Just on the first one on the IHI and the individual health identifier and the EHR. There's no doubt, and the Sláintecare report calls this out, where the areas that are behind are in terms of e-health, and we've been trying, as we've been working through various deployment of both vaccination, testing and tracing programme, to capture information which will contribute to significant data to contribute to those projects, but they are the ones that we are behind on in terms of progress. They are ones we want to put a particular focus on, and particularly in terms of e-health, we will need to recruit expertise. We don't have sufficient expertise in the HSE in particular, and the cyber report that we published, the PwC cyber report, did call out deficiencies in some of our skills, which will be part of our recruitment process to strengthen ourselves in that sector. And finally, just to make a comment on the change management, you are correct. I'm not from health. 2.5 years here, but we will need to bring in some expertise, and we will need to bring some external expertise. This is, as I said earlier on, one of the biggest change management processes in a public service body, probably in the history of the state, and we do need to bring expertise in with us. And finally, I have actually also as well met the team from the Trinity Centre in my early stages.
And sorry, just on the workforce plan, have you only got one for the current year?
I'm happy. Sorry, apologies. I meant to come in on that. So we have two aspects. Deputy, one was Robert's correct. As we publish a national service plan, we then have a pay and number strategy for 2022, and then separate to all that, we are working with our board on a strategic workforce plan, which sets out a multi-annual plan to address it, and we'll be working with the department on that as well.
Over how many years are you talking about?
It's a multi-year plan. It literally sees us it's for duration of a corporate plan, which sets us out to 2024.
Okay, thank you.
Okay, thanks very much. I think it was very informative this morning. I hope we can do this on a regular basis to try and keep abreast of the implementation of Sláinte Care. So the committee will now meet again in public session next Wednesday, the 23rd of February at 9:30 a.m. And again, thanks very much for all our guests this morning. Thank you. Slán.
Thank you, Chair.